Welcome back, dear friends. Welcome back to the second half of the today's class. We are doing conjunctiva, diseases of conjunctiva. The next topic which I'm going to do is a very high yield topic, and the questions they have been coming through this topic in various exams. So let's begin once again. Let's begin once again in conjunctiva, and now we are going to discuss trachoma. We are going to discuss trachoma. Right. So trachoma, dear friends, is a chronic conjunctivitis. Okay? It's a chronic conjunctivitis of the children. Okay, the disease, the infection, first of all, starts in children. It's more common in children. Which age group? 1 to 9 years of age. The major vector, it's the flies, unhygienic conditions, the flies, they transmit the disease from one person to another person. What is the causative organism? The causative organism is Chlamydia trachomatis, but which serotypes? Now, this is important to know which serotypes. Serotype A, B, BA, and C. So please mark it as important. We discussed Chlamydia trachomatis, serotype D to K causes swimming pool conjunctivitis. But A, B, BA, and C, they cause chronic conjunctivitis, which is called trachoma. Okay, so this we have already discussed, that adult inclusion or swimming pool. And this is your trachoma serotypes. Okay. Now the clinical features, the important clinical hallmark features of trachoma, one is intense itching. Okay, there is intense itching. The follicular reaction, so that is why trachoma is marked by specific follicular reaction. Follicle formation, I have shown you how the follicles, they look like earlier also. So follicle formation is the hallmark of trachoma. These follicles, they can be present on tarsal conjunctiva, as you are seeing here. The follicles in trachoma, they are specifically very big in size. Okay, so you can see these follicles here. They are specifically very big in size, and they are called sago grain follicles, like sago grains. Okay, again, important question. Sago grain follicles are the large follicles which are seen mostly in upper tarsal conjunctiva. They are hallmark feature of trachoma. Now, these follicles, they can also be present on limbus. Okay. If they are present on limbus, then they are called Herbert follicles. Okay. So sago grain follicles, I already showed you, they are present in upper palpebral, or what we call as tarsal conjunctiva, tarsal or palpebral conjunctiva. When they are present at limbus, these follicles are called Herbert's follicles. So again, an important question here. In the healing stage of the disease, in active stage, there is follicular reaction. In healing stage of the disease, these follicles, they leave these depressions here. They leave these pits or depressions here. Then they are known as Herbert pits. So if you see Herbert pits in a patient, you know that this patient had trachoma, active trachoma in the past. Okay? So 3 features here, all important. sago grain follicles, which are seen in upper tarsal conjunctiva or palpebral conjunctiva, inactive stage of disease. Similarly, Herbert follicles, which will be seen at limbus, inactive stage of disease. Then Herbert pits, they are seen in healed trachoma. So they indicate a sign of old trachoma involvement. Okay, right? So then what all other specific features are? You will notice Art's line. Art's line. Okay, what is Art's line? Now these images, they are more for your understanding. I will tell you which image can come in exam as image-based question. These are more for understanding. Now Art's line, as you notice this scarring, this fibrous scarring in the upper tarsal conjunctiva. So it is a fibrous scarring again in tarsal area. Tarsal area is a part of the lid, this tarsal area. So this is known as Art's line. So again, it is seen in the healing stage or the scarring stage of the trachoma disease. Then as a sequelae of the trachoma, the patient can develop what is known as tracheasis. Okay. What is tracheasis? So as you notice here, tracheasis are that the eyelashes, they are misdirected. They are rubbing at the cornea. So tracheasis means, you can write here, misdirected eyelashes. They can rub cornea. When they rub cornea, they can cause corneal injury, which can lead to corneal ulcer formation. Okay. The corneal ulcer can heal, but it can lead to corneal opacity, that the cornea becomes opaque, again scarring. And then a vascularized corneal opacity is commonly seen in trachoma, which is known as pannus formation. Okay. So again, this is a feature of trachoma. Okay. Vascularized corneal opacity, which is known as pannus, is again a feature of trachoma. Okay. So coming back once more, because all these features, they can be asked as questions. Let's revise them here itself. So trachoma, I'm going to tell you the classification of trachoma, but you can see there will be a clinically active stage, that is inflammatory stage. And then there will be, when it heals, it produces various sequelae or the scarring. In the clinical stage, the patient will have follicular reaction. And this follicular reaction, when the follicles, they are present on the conjunctiva, they are called sago grain follicles because they are big in size. When they are present at limbus, it is called Herbert follicles. When Herbert follicles, they heal, they leave Herbert pits, the small depressions in the limbal area. Then in the scarring stage, there can be formation of Art's line, which is a fibrous scarring in the tarsal area of the lid. There can be tracheasis, which is the misdirected eyelashes, which are rubbing the cornea. They can lead to corneal ulcer. Corneal ulcer, when heals, can lead to corneal opacity. A vascularized corneal opacity. So normally the cornea is avascular, but a vascularized corneal opacity is often seen in end stages of trachoma, and this is known as pannus formation. Pannus formation. Okay. Now the trachoma has been classified by WHO, the different stages, as I told you, inflammatory stage, healing stage, scarring stage. So it is classified, a Fisto classification is given. The Fisto classification is given by WHO. So we need not go in very much of detail of this. Please remember the name. Okay. Fisto classification. So this one-liner question sometimes can come. The Fisto classification is the classification which is associated with the different stages of trachoma, and it has been given by WHO. Right? Now, how to treat trachoma? So for the chlamydia treatment, we have discussed even in the ophthalmia neonatorum, what will you give? We give the antibiotic. The antibiotic can be given as a topical, that is a local treatment. The local treatment, the drug of the choice is 1% tetracycline ointment. Okay, 1% tetracycline ointment. If you want to give the systemic treatment, then we give azithromycin. A single dose azithromycin is given as a drug of choice. The single dose azithromycin is given as a drug of choice. So please highlight this point. This is again an important point, can be asked in the question also. Okay. The doses in children, we give 20 milligram per kg body weight, and for adults, we give 1000 milligram dose. I think it should not be per kg. Right. So topical tetracycline and systemic azithromycin. Now, there is, like, trachoma is one of the important common cause of preventable blindness. Okay, because I told you trachoma can have corneal opacity, corneal ulceration. So it is an important cause of preventable blindness. And in certain areas of the world, trachoma is endemic. Okay, it is endemic. So WHO has taken trachoma for the disease control, for the elimination of trachoma as a public health program. WHO has given specific strategy for the control of trachoma. And this strategy is called SAFE strategy. This strategy is called SAFE strategy. Now, this is the high yield point because question has been coming on this. The SAFE strategy. SAFE strategy is for the control of trachoma. This is the strategy given by WHO to eliminate trachoma in the endemic areas. And what does SAFE stands for? The S is for your surgery. In advanced diseases like tracheasis is there. So the surgery for the tracheasis, entropion, that is the S for SAFE, the surgery. E in SAFE stands for antibiotics, the use of antibiotic to clear trachoma infection. So antibiotic, I told you, azithromycin. The F stands for facial cleanliness because the disease spreads from the unhygienic condition through the flies. So the facial cleanliness is also the part of the control. And E stands for environmental improvement, again to prevent the transmission through the vector. Now, this is a high yield question. I'm again telling, they can ask you what is SAFE strategy, which disease the SAFE strategy is used for, that is trachoma, and what is the meaning of SAFE. S stands for surgery. A stands for use of antibiotic for trachoma infection clearance. F, this was the question, the F stands for facial cleanliness. E stands for environmental improvement. Okay, so please remember these points about trachoma, one of your important topics there. Okay, so give a minute for yourself for the trachoma. Okay, right? Okay, so after discussing trachoma, I'm going to move to the next topic, which is again very important and very high yield. Almost in every exam, one question based upon allergic conjunctivitis is coming, beta. So you were asking me about the high yield questions. So allergic conjunctivitis is your one high yield topic. Allergic conjunctivitis is your one high yield topic, right? So let's start with allergic conjunctivitis. Now in allergic conjunctivitis, always one should remember one hallmark symptom of allergy is itching. Okay? And the second hallmark sign of allergic conjunctivitis is formation of papillae. See the difference in trachoma. The hallmark was formation of follicles. In allergic, the hallmark is papillae formation, right? Now, allergic conjunctivitis, one can be like, acute allergic conjunctivitis, in which the patient has acute symptoms. Now, this can be sometimes specific to certain season, that is seasonal, or it can be some people, they have allergic to the exogenous agents which are perennial, right? That is throughout the year. Now, the acute type of allergic conjunctivitis needs to be treated mostly by the eye drops. Which eye drops which we can use? The drops which are used are your mast cell stabilizers and antihistaminics. Okay, so they are available for the treatment of allergic conjunctivitis. Now, there is a specific type of the allergic conjunctivitis by the name of vernal keratoconjunctivitis. Now, this is your very, very high yield topic. Okay, this is your very high yield topic. The question based upon the clinical case scenario of VKC, sometimes the image-based question, it has been coming very often. So let me tell you what is VKC, and then I will give you example how the question is going to come. Okay, so please concentrate, please focus. It's very simple to understand, but very high yield topic. Now, VKC or spring catarrh is a type of allergic conjunctivitis only. Okay, allergy, as you know, is the type 1 hypersensitivity reaction to any exogenous agent. Any exogenous agent can be a pollen, heat, dust, or whatsoever. Okay. No follicle, I told you already, only papillary reaction is seen in VKC. It's more common in younger age group, okay? More common in males. So usually in the history, they will be talking about a young boy. So a young boy showing the features of allergy, please think of spring catarrh or vernal keratoconjunctivitis. Okay, so what can be the features? The clinical features are the patient will have symptoms of itching, redness of the eye, very important, ropey or stringy discharge, a foreign body sensation, as if something is there in the eye, grittiness or foreign body sensation. So these will be the features in the history of the clinical case scenario. Okay. Then again, another thing is the symptoms, they are more common in summer season. Though the name is spring catarrh, but symptoms are more common in summer season. So a young boy who is presenting with itching, ropey discharge, very important. Ropey discharge is very important. Redness, foreign body sensation, symptoms more in summer season. So even this much is enough to make a diagnosis of VKC or spring catarrh. Now, what are the clinical signs which you see? Now, spring catarrh, based upon the clinical presentation, it is of 3 types: bulbar, palpebral, mixed type. Okay, so by now you know the meaning of bulbar and palpebral. Bulbar means when the signs are more on the eyeball, the ball area. Okay, palpebral means when the signs are more on the lids. Okay, so here, like, signs are more on the lids, so this will be palpebral type. Here you see the lower picture, the signs are more on the eyeball itself, so this will be bulbar type, or it can be mixed type. Okay? So you can now think of bulbar means when something is related to the eyeball, palpebral means when something is related to the lids. Now these two are important clinical signs of the VKC. So these can be shown as image based. So you can write here, this can be shown as an image based question. Okay. So there will be history. There will be a history that a boy coming with itching, ropey discharge, and this is the clinical picture which you see. So what do you notice here? I think you can identify. I told you in the beginning of the chapter itself, friends, come on. You can tell me straight away the diagnosis. What you are seeing here, you are seeing these papillae, the flat topped papillae. Now they can be small in size. It is not necessary that every time they have to be big, but when they are big, they give the cobblestone appearance. They give the cobblestone appearance. Again, your question. So you will see the papillae giving cobblestone appearance to the eyelids. Then second important sign is presence of what is called Horner-Tranta spots. Again, a question here, Horner-Tranta spots. Horner-Tranta spots are these papillae when they are present on the limbus, these gelatinous, again, a kind of papillae only, gelatinous hypertrophy on the limbus. This is Horner-Tranta spot. Again, it is a feature of VKC or spring cataract. Then sometimes the cornea can get involved. Then there is an ulcer formation, and this ulcer is known as shield ulcer. Again, important question. Okay. So this will not be shown usually as an image. So here you see the papillae, they are not that big. They are small papillae, right? And there is an ulcer on the cornea. If there is an ulcer on the cornea, that is called shield ulcer. The corneal ulcer in a case of VKC is called shield ulcer. Then there can be what is known as pseudogerontexon. Pseudogerontexon, or also called as Cupid's bow. So this picture is just to make you understand what is Cupid's bow. These, you are seeing this peripheral corneal opacity here. Okay, so this peripheral corneal opacity is called Cupid's bow or pseudogerontexon, which can be seen in the cases of VKC. So these are the important signs of VKC. So now, how the question is going to come, how the clinical case scenario, which has been coming many a time. So listen to me. A young boy is brought by his mother with the complaints of itching, ropey discharge, redness of the eye, which is more in the summer season. On examination, the following image is seen. What is your diagnosis? So what is your diagnosis? Your diagnosis is vernal keratoconjunctivitis. Okay, so this can come, as you can write here, this can come as a case scenario or clinical case scenario question. It has been coming in the past exams. The other questions can be Horner-Tranta spot seen in VKC, shield ulcer seen in VKC, pseudogerontexon or Cupid bow seen in VKC. So they can be your one-liner questions. Okay, right? Now, how to treat? How to treat? So again, since it is a type of allergic conjunctivitis only, so you are going to give the medication which I told you already, mast cell stabilizers and the antihistaminics. Okay, mast cell stabilizer and antihistaminic. Sometimes you also need to give mild topical steroids also. Okay, right? So even if you don't remember the name of the drugs, it's fine. It has been mentioned for your knowledge here: olopatadine, apinestin, beptostin, mild topical steroids. So they all can be given, for VKC. But thing to remember is the principle of the treatment. The principle of the treatment is that you are giving mast cell stabilizers, you are giving antihistaminics, and you are giving the mild topical steroids. Okay, right? So give yourself a minute to think about the VKC, what I have told you. The VKC is allergic conjunctivitis seen in young boys in summer, specific features, clinical case scenario, the image of papillae, cobblestone appearance. Please don't forget it. Very high yield topic for your exam. Okay, right? Okay, so here only I will mention in the VKC at the end of this or somewhere here, you can put your notes here. Let's put our notes here. The one differential, which is seen is, that is, please write down, giant papillary conjunctivitis. Giant papillary conjunctivitis. Please write it down. Now, this is another clinical case scenario for which the question has been coming. Now, giant papillary conjunctivitis is again a type of allergic conjunctivitis, which is seen as allergic reaction to contact lens use. Okay, so here the risk factor is contact lens use. Contact lens use. Okay, please write it down. So again, the patient will have similar history. The patient will have itching. The patient can have mucoid discharge. There will be papillae. That is why the name giant papillae. So there will be giant papillae seen, giving the cobblestone appearance. Similar kind of picture. So how will you differentiate this from a case of VKC? Number one, there will be always mentioned the use of contact lens. If this allergy picture with papillae is with the use of contact lens, then the diagnosis will be giant papillary conjunctivitis. And it will not be associated with season, no association with the season. It will be more common in the age group where the contact lenses are used. So not in children, adolescent and adults. So it will be more common in adolescents or adult, and no sex predilection. It can be either male or female. Okay, so this is how you will differentiate between two different clinical case scenario, because both of them, that's why I'm spending a bit time here, beta, because both of them, they have been coming in your exam. So there will be one clinical case scenario. Please mark it as very important. VKC, there will be another clinical scenario, giant papillary, which have overlapping features. Both will have itching, both will have papillae, both will have mucoid discharge. So how to differentiate? VKC, when it is associated with younger age group, children, more in males, associated with summer season. Okay, right? And giant papillary conjunctivitis, when it is associated with contact lens use, most important, contact lens use, and no season association, no male or female predilection, and it will be more common in adult age group or adolescent age group, the people who use the contact lens. Okay, so hope I am clear in differentiating between these two clinical case scenario. Very simple, but very high yield. Okay. Okay, so after this, let's go on to another condition in conjunctiva, which is your phyllectanular keratoconjunctivitis. Phyllectanular keratoconjunctivitis. Now, what do I mean by phyllectanular conjunctivitis? Now, here another thing is the keratoconjunctivitis means cornea and conjunctiva both involvement is there. Okay. Now, this is now GPC and VKC, that is giant papillary and VKC, they are bilateral, mostly bilateral. Now, this is mostly unilateral. Okay. Then it is a type 4 hypersensitivity. It is not an active infection. It is type 4 hypersensitivity either to staph or to tubercular antigen, especially in countries like India, where tuberculosis is endemic, right? So type 4 hypersensitivity to staph infection or tubercular antigen in the body, it leads to phyllectanular keratoconjunctivitis and more common in children. And what is the clinical appearance? There is development of, as you are seeing here, these yellowish nodules close to the limbus. So limbus, okay? Close to the limbus area, there is development of these yellowish nodules. So these are features of phyllectanular conjunctivitis. And they can involve the cornea also. If they involve cornea, they can lead to an ulcer formation. And this type of the ulcer is called fascicular ulcer or sacrophilous ulcer. Okay. So all these 3-4 points which I have mentioned, they can come as question. So this is again a high yield topic for you, phyllectanular keratoconjunctivitis. Question can be, the yellowish limbal nodules are seen in which condition? Phyllectanular keratoconjunctivitis. Okay. What type of the hypersensitivity reaction it is? It is type 4. What antigen or organism you can say is implicated in India? Tuberculosis, otherwise even the staph, right? And what is the type of ulcer which can be seen in phyllectanular keratoconjunctivitis? Fascicular ulcer or sacrophilous ulcer, right? So again, simple to remember, but high yield can be asked in your exam, right? Okay. Then moving on to another topic, and the question had come in the last exam based upon this topic. We are now going to discuss few conjunctival degenerations. First of which is xerophthalmia. Xerophthalmia. So again, beta, please mark this one as high yield topic, because even in your last exam, the question had come. Even in NEET PG, the question has been coming about this. Okay? Now, what is xerophthalmia? Xerophthalmia means the ophthalmic manifestations of vitamin A deficiency. Okay, so all the eye manifestations of vitamin A deficiency, that's called xerophthalmia. So what is basically happening? You know, in vitamin A deficiency, the epithelium of conjunctiva, what I told you, bache, the epithelium of conjunctiva is non-keratinized. So there occurs metaplasia of this conjunctiva. It becomes keratinized. So when it becomes keratinized, the mucin cell, the mucin generation, the goblet cells are going to die. So it becomes keratinized. The eye surface becomes dry. That is why xerosis. Xerosis means dry conditions. So vitamin A deficiency leads to keratinization of conjunctival epithelium due to metaplasia, and the eye surface becomes dry, which leads to all the complications related to vitamin A deficiency in the eye. So let us see what are the features. Okay? Let us see what are the features of vitamin A deficiency. So there is a WHO classification for vitamin A deficiency. You can complete the heading here. Vitamin A deficiency. So this is the classification. Concentrate on the chart. There is the first stage is XN. XN stands for night blindness. Night blindness is, please write down, first symptom of vitamin A deficiency. Before any sign develops, a person can have night blindness as first symptom of vitamin A deficiency. Okay. The second is your X1A, which is conjunctival xerosis. Conjunctival xerosis is first sign of vitamin A deficiency. Please write down. First sign of vitamin A deficiency. Okay. Night blindness, you can write here, is also called nyctalopia. Nyctalopia. So please write down this word because sometimes this word can be used in the exam also. Nyctalopia means night blindness. Friends, nyctalopia means night blindness, which is the first symptom. Then conjunctival xerosis. Xerosis, I told you, dry. The eye loses its shine. The eye starts looking dry. Okay. The second stage is when there is formation of bitot spot. Bitot spot. Okay. I will show you the bitot spot just now. Okay. So these stages, they are in addition to the upper stages. Okay. So after conjunctival xerosis, the next stage in severity is bitot spot. Then X2, corneal xerosis. Corneal surface also becomes dry. Okay. So when corneal surface becomes dry, there is always risk of corneal ulceration. Okay. So that is X3 stage. Now this corneal ulceration, when it involves less than 1/3 of cornea, less than 1/3 of cornea, that is X3A. When it involves more than 1/3 of cornea, it is X3B. Okay. And this corneal ulceration, please write it down. It is also known as keratomalacia. Another terminology which is used for vitamin A deficiency, keratomalacia. Please write it down. Keratomalacia means the cornea is getting sloughed off, melting away, corneal ulceration. Okay. So X3A or X3B, corneal ulceration or keratomalacia. Okay. Then the stage of corneal scarring, you know, if the ulcer heals, it will always leave a scar. That is XS. And the retina changes. The vitamin A deficiency can produce changes in the retina also. The retina changes are called xerophthalmic fundus. There are pigmentary changes. Pigmentary changes in retina. Pigmentary changes in retina. So these are the different signs, multiple kind of questions they can come. Nyctalopia, night blindness, one of the differential will be vitamin A deficiency. What is the first symptom of vitamin A deficiency? Night blindness. What is the first sign of vitamin A deficiency? Conjunctival xerosis. Okay. Bitot spots are seen in vitamin A deficiency. Keratomalacia is seen in vitamin A deficiency. Okay. Corneal xerosis is seen in vitamin A deficiency. So all these, they can come as questions. Okay. And the latest question was about the bitot spot. Now this can come as an image-based question. Please mark it, beta. Very, very high yield. The question came in the last exam, also in the NEET PG exam. So what is bitot spot? How you will identify? Bitot spots are seen on the bulbar conjunctiva, as you are seeing here. Mostly temporal, not necessary, but mostly temporal. Okay. This kind of, you see, white, frothy or foamy lesion. So I don't think it is easy to miss this if you have seen ones now. Image-based question, bited spot, or it can be this lesion seen along with conjunctival xerosis in which condition? Vitamin A deficiency. White, frothy, foam-like spot on the temporal conjunctiva, mostly bited spot, feature of vitamin A deficiency. So mark this picture in your mind, beta. Don't forget this picture, bited spot, vitamin A deficiency. Okay, right. Now this is mostly for your understanding what is keratomalacia. So you can see how the cornea is getting melted away. Keratomalacia, the whole cornea. So it is a blinding. Vitamin A deficiency is a potentially blinding condition. The child can go blind within hours due to vitamin A deficiency once it reaches the stage of keratomalacia. Okay, so that's why it's clinically also very important. Now, since it can have such devastating effects, so the treatment, the WHO has given specific treatment guidelines for that. If it is only mild stage, for example, the stage of xerosis or dryness, you give lubricants. Of course, once the ulceration is there, it has to be treated as the treatment of the corneal ulcer, may require even keratoplasty, etc. We'll be discussing that in the chapter of cornea. Okay. And vitamin A therapy. So this is important to know the dose of the vitamin A therapy. You will be learning in your community medicine also. The doses, 3 doses are given on day 0, on day 1, and on day 14. Day 0, day 1, and day 14. If the child is less than 1 year of the age, oral dose of 1 lakh international units of vitamin A. If the child is more than 1 year of age, oral dose of 2 lakh international units. And if you want to give injectable, reduce it to half of the oral dose. So this is the WHO recommendation. Okay. Oral dose less than 1 year, 1 lakh, more than 1 year, 2 lakh. If you are giving injectable vitamin A, half of the oral dose. Okay, right? So everyone, bited spot, conjunctival xerosis, corneal xerosis, keratomalacia, nyctalopia. Don't forget these terms and don't forget vitamin A deficiency. Okay, right? So moving on to the last part of the conjunctiva, the conjunctival degenerations, another important, simple, very, very high yield topic. Question coming in every exam, nearly every exam, beta pterygium, mark it with any number of stars you want to mark it. Pterygium. So two commonly seen conjunctival degenerations are, one is known as pterygium, the second is known as pungicula. Right? So let us discuss with pterygium. Again, all your concentration here, beta. Very important topic. Question came this year also. Every year question is coming on pterygium. Right? So what is pterygium? Now, pterygium is a degenerative condition. So there is a degeneration, but at the same time, there is hyper, you can say trophy or hyperplastic changes also. Okay, that is proliferation. Okay? So what happens? There is hypertrophic. Look at the figure here. Okay, there is, you see these fleshy growth which is coming. First, see the figure. Okay, we'll write it down also. This fleshy growth which is coming from the conjunctiva and it is encroaching the cornea. So this is elastotic degeneration of conjunctiva, which involves the corneal layers, Bowman layer, stroma, which involves these layers. Okay, so we define the pterygium as, you can write here, fleshy, triangular, wing-like growth. Okay. So it is a degenerative condition, but there is hyperplasia also. So it appears like a growth. Please write down fleshy, triangular, wing-like growth, which encroaches upon the corneal epithelium. These are the layers of cornea. We are going to discuss cornea very soon. Bowman membrane and stroma. Okay, so that encroaches upon these layers. Now, what is the etiology? So there are certain risk factors. The exposure to ultraviolet rays, dry heat, dusty environment, it kind of exposes you more to the risk of development of pterygium. So people who are working for long hours in, like, high heat, for example, the farmers, the field worker, the laborers, so who are exposed to this kind of thing, they are more at risk of developing pterygium. The growth of the pterygium is more common, as you are seeing, in the nasal area. So you can write it down here. It is more common in nasal part. That is, nasal part means towards the nose. The nasal part, the part of the eye which is towards the nose, is called nasal part, which is away, that is called temporal part. So nasal and temporal. Okay. So it is more common in the nasal part. Right. Now the pterygium can be, it can be divided into having different parts as they are mentioned here, right? So there is a head part, the head, which is on the cornea, the leading edge, you can say. Okay. Then there is a neck part, which is on the limbus area. Okay. And then there is a body, which is between this canthus, the inner canthus, and the limbus. Right? So it can be divided into three parts: head of the pterygium, neck, and the body. And then a small cap just in front of the head, which is basically, you can say, the advancing edge. The advancing edge is called cap. Okay, right? Now, there can be another association with the pterygium, what is called as Stalker's line. Stalker's line. What is Stalker's line? Please write down. It is the iron deposition in cornea in front of pterygium head. So in front of the head of the pterygium, there can be, pterygium head. Iron deposition. Okay? The iron can get deposited in the cornea in front of the pterygium head. That is known as Stalker's line. So this can also be your one-liner question. Okay, please mark it. Stalker's line, your one-liner question. Okay? So just briefing you about the pterygium. A fleshy, triangular wing-like growth, okay, which encroaches on the cornea. The risk factor: ultraviolet rays, dry heat, dusty environment, more common in the nasal part. There can be Stalker line associated with it. What is Stalker line? It is iron deposition in the cornea. Now, this can come as your image-based question. Please mark it. This can come as your image-based question, that you show, you are given this image, that the following image is seen in a patient eye. What is the diagnosis? So simple. Or the question can come, Stalker line is associated with. The question can come based upon the risk factors associated with pterygium. Okay. Then what to do? What is the management of this pterygium? Now the management will depend upon how much is the growth and how are the symptoms of a patient. If the pterygium is very small, okay, it can be like, small, medium sized, bigger sized. If the pterygium is small and the patient is asymptomatic, of course you don't do anything. You can leave it like that. Or the patient can feel cosmetic problem. There is this growth, it doesn't look nice on the eyes. So it can cause a cosmetic problem. It can cause astigmatism when something is encroaching on cornea. So it affects the corneal curvature. And it can cause astigmatism, what we call as WTR, means with the rule astigmatism. WER means with the, we will discuss in the refraction chapter. Astigmatism means a refractive error with the rule astigmatism. Okay. If the pterygium is very big, it can cause diplopia. Diplopia means double vision. Diplopia means double vision, or restriction of the movement, because it's a growth. It can restrict the eye movements. And if it covers the pupil, if the pupil gets covered, if this area gets covered, then the vision will be affected because the light is not able to enter the eye. So depending upon the size of the pterygium, you can say a person can have different clinical features. He may be asymptomatic. Cosmetically, it is not looking good. The patient is having astigmatism, double vision, patient is having decreased vision. So the treatment will depend upon the severity. Okay, right? Now, so how will I be then treating? So if the patient is not bothered, he's asymptomatic, leave it alone. Don't try to remove it. So asymptomatic, leave it alone. But if it is causing problem, as I told you, astigmatism, decreased vision, then you have to do the surgery. Then the treatment is surgery. Now, this is important, very high yield, because the questions, they have come based upon the surgical treatment of pterygium. Now, you can do three things. One is you do simple excision. Okay, you excise the pterygium, you removed it. This is called bare sclera technique. But this is not the preferred method because it can cause high recurrence. It can cause high recurrence. To prevent the recurrence, the people, they use MMC. What is MMC? Mitomycin C. Okay, so this can be a question, that what is done to prevent the recurrence of pterygium after surgery. What is done to prevent the recurrence of pterygium after surgery? You use mitomycin C. The other surgical procedures are that you do excision and you put an autograft of conjunctiva. That is, you take the conjunctiva from the other part of the eye and put it where you excised the conjunctiva. Okay, so this is the best method. This is the best method. Conjunctival autograft. Okay, excise and conjunctival autograft, because this will also prevent recurrence. This will also prevent recurrence, and this is also treatment of recurrence. Okay, right? Now you can ask me that mitomycin and conjunctival autograft, which is better? Conjunctival autograft is better because mitomycin can have its own complications. Mitomycin is a kind of a antifibrotic agent. It can have its own complications. So best method, if one has to see to prevent recurrence and treatment of recurrence, please mark conjunctival autograft as an answer. So this can be your question. Another method which is used is, you can also use amniotic membrane graft. Okay, amniotic membrane grafts are available to be used in eye for different purposes. Pterygium surgery is one of those that can also be used. But out of all these, conjunctival autograft is best because it has less complication than mitomycin C. It is easily available. Amniotic membrane graft may not be available in all the center, but conjunctiva is you are taking from the patient's own eye. You can take the conjunctiva from the temporal part and put it on the nasal part. So this will be the best method for preventing and treatment of recurrence. And this was the question in this year exam, beta, that what is the best method for treatment of recurrent pterygium or pterygium? Please mark conjunctival autograft as your answer, right? So this is your pterygium, a simple topic, high yield topic. Question can come based upon the clinical features. Question can come based upon mostly on the treatment it has been coming. Question can come based upon the image. Okay, right? Pterygium, guys. And then just few words about Pingicula. Honestly, the few words, just to let you know, because this is one of the commonest degeneration which is seen. Okay, so you see this nodule here on the conjunctiva, a yellowish gelatinous nodule. This is your pingicula. It is again a degeneration. So it is an elastotic degeneration, but there is no hypertrophy, no encroachment of the cornea. Okay, so just as a differential, pingicula, please remember the image, that it is a kind of elastotic degeneration appearing like a gel-like mass on the conjunctiva. Mostly we don't do anything for this. We leave it just like that. Okay? So that is your pingicula. Okay. Okay, friends. So here we finish our conjunctiva, and you have few questions there in the workbook. The workbook questions are very, very simple to let you just see the important points, to kind of rehearse what you have done. And you will be getting a lot of questions. I'm going to post the questions on the Telegram channel to revise your topics. Okay, try to do the questions. We will be giving you the mock test. We'll be giving you your regular test, which will help you to attempt the questions. When you attempt the questions, you get an idea how to revise your subject. Okay, my effort has been even today to let you know that this is for your understanding. This is your point-wise question which can come. This is how your image can come. So your preparation, the first reading is to understand the subject. The second reading is always needed, where you look at those high yield points and you learn them, revise them, absorb them the way they are going to, come in the exam. Right? So that will be, I'll be putting the questions from the topics which we keep doing, that how the questions they have been coming in exam. So that will give you a fair idea how to, do the subject, how to learn the subject, how to revise the subject. And as I told you in the beginning itself, it can be very overwhelming when a lot of new terms, new condition, new picture, ma'am is showing so many images. Some images are for your understanding. Some images, they come in the exam. Some images, they help you retain the subject. So that has been our effort in compiling this workbook. Okay? So conjunctiva, we did the infections, viral, bacterial, trachoma, ophthalmia and neonatorum. We did allergy, VKC, giant papillary conjunctivitis, phyllectanular conjunctivitis, and we did vitamin A deficiency, important, very important. We did trachoma in the infections, very important. We did pterygium, the degenerative condition, very, very important. Okay, so just a quick revision of your workbook questions, which you can do with me. So drug of choice of trachoma is, so here, if you see the choices are penicillin, azithromycin, tetracycline, chloramphenicol. Now you know, I told you both these drugs are given, tetracycline also, azithromycin also. So if you have to choose between these two, what will you choose? Mark azithromycin because it is a single dose therapy. It is a single dose therapy. So that will become the drug of the choice. Okay, right? Now, this you can easily tell me, Horner-Tranta spots are seen in Horner-Tranta spots. Better read the choices. VKC, active stage of trachoma, healed stage of trachoma, pilectanular conjunctivitis. So remember, Horner-Tranta spots are seen in VKC. Yes, you are very right, VKC. Then, Herbert follicles are seen in. Now remember, Herbert follicle. Follicle, I told you, inflammatory stage of the disease, active stage of the disease. So Herbert follicle are seen in choices, VKC, active stage of trachoma, healed stage of trachoma, pilectanular conjunctivitis. So guys, follicle means active stage of trachoma. If it is Herbert pit, that will be healed stage of trachoma. Okay, right? Then, very easy one, the shield ulcer is seen in. Shield ulcer, a complication of, I told you, vernal keratoconjunctivitis. Vernal keratoconjunctivitis. Okay. Which of the following causes acute hemorrhagic conjunctivitis? Acute hemorrhagic. So I told you, please remember viruses, some viruses was there. Which one causes acute hemorrhagic conjunctivitis? Out of these, adenovirus. Okay, right? So these were some simple examples. We'll be coming up with more questions for you to practice your subject. Okay, practice your chapter, practice your topic. So we are done with the conjunctiva, and now we will be moving on to cornea. And discussing the diseases of cornea. Right? If you want to have some sip of water before starting the new topic, you can have that. Right, friends. So take a few deep breaths to imbibe another new topic there, cornea. So all set to start cornea, another topic in ophthalmology, which will have 2 to 3 questions based upon the different conditions here. I will be letting you know. Now, the importance of the cornea, friends, is, in the beginning of the class only, I told you what is the purpose of the eye. So eye is a sensory organ, and cornea is one structure of the eye which is designed absolutely to help in completing that function of the eye, that is help to see. And to see, what I told you, you have to receive the light. You have to receive the light coming from the different objects. Okay, so cornea is absolutely clear. Okay, the cornea is absolutely clear to serve that purpose only. Okay, so nature has made cornea transparent clear structure so that light can pass through the cornea unhindered, unobstructed. Okay. So and it is the outermost layer. So you can see the cornea is the outermost, the part of the fibrous coat of the eyeball. So when the light strikes, it first of all strikes the cornea, right? So any disease of the cornea will affect the passage of the light through it. So that is why the corneal diseases, they can be potentially blinding, because if the light cannot pass through the cornea, you will not be able to see. So there will be deficiency, there will be decreased in vision. Okay? So that is, highly important structure in the eye for normal vision is your cornea, right? So we saw in the beginning itself only that cornea is a part of the outer fibrous coat. The junction between the cornea and sclera, I had told you, is called limbus. Okay. Now, some more features of the anatomy and physiology of the cornea, which help in making the cornea refractive surface, the most important refractive surface of the eye. Okay. Now, the points to be remembered in the anatomy, or the, you can say, corneal dimensions. So cornea, you are seeing the shape of cornea, isn't it? This is your cornea. Now, cornea is not absolutely circular. Okay, the anterior surface of the cornea is not absolutely circular. The horizontal diameter is slightly more than the vertical diameter. Okay, so the cornea is, the horizontal diameter is more, the vertical diameter is slightly less. Horizontal diameter is 11.7 millimeter, vertical diameter is 11 millimeter. Okay, so the anterior surface is little elliptical. You can see it is not circular, it is elliptical. Posterior surface is circular. The posterior surface has equal diameters horizontally and vertically. Okay? So this is one understanding about the curvature or the dimensions of the cornea. Then, important terminology: if the corneal diameter is less than 10 millimeter, if it is less than 10 millimeter, then we call it as microcornea. Microcornea, small cornea. Micro means smaller. Okay? If the diameter is more than or equal to 13 millimeter, it is called megalocornea. Megalocornea. Okay. So microcornea, if the diameter is less than 10 millimeter, microcornea less than 10 millimeter, megalocornea more than or equal to 13 millimeter. Then I told you the main thing about cornea is the light strikes. So when light strikes the cornea, it undergoes refraction, bending of the light rays, because light has to focus on the retina. Okay, so it has to be refracted, so bending. So it is one of the most important refractive surface because it has high refractive power. Okay? The total refractive power of the eyeball is, the total refractive power of the eyeball is 60 diopter, out of which 43 and 43 to 44 diopter plus is contributed by cornea. So which is the most strongest refractive surface? That is your cornea. Okay? And cornea is making an air corneal interface, because this is air, the atmosphere. The light first of all is touching the cornea, or cornea is also covered by a tear film. So the precorneal tear film or the cornea interface is the most important refractive surface, right? Just for the knowledge, refractive index of the cornea is 1.376 because the index determines how much is the refractive power of a surface. So these are some optical parameters. We will be discussing them in the refraction chapter also, but this is just to highlight here. Nothing much to memorize here, beta. Just remember 60 diopter is the total eyeball power, 43 to 44 is contributed by cornea. Now regarding the thickness of the cornea, okay, so cornea has an average thickness of 540 micron. It is more thick in the periphery. So you can write here the corneal thickness, it is thick in periphery, that is the limbal part, and thin in the center. Okay, so that is the thing to remember about corneal thickness, thick in the periphery, thin in the center. So these features, they give you idea. The anterior surface is elliptical, posterior surface is circular, average size, I have told you, average corneal thickness, refractive power contributing plus 43 to plus 44 diopter of the refraction, most important refractive surface. Now, the cornea is a multi-layered structure. Cornea is a multi-layered structure. Let's learn about the layers of the cornea. There are 6 layers of the cornea. 6 layers of the cornea from top to bottom or from anterior to posterior. The anterior most is corneal epithelium. Then comes Bowman membrane, corneal stroma, Duas layer, Descemet membrane, endothelium. Okay, so from outer to inner. So this figure is the diagrammatic representation. So let's have a look at this figure, the diagrammatic representation of different corneal layers. Okay, so just have a look along with me. You notice this is the epithelium. Epithelium is stratified. It is stratified, squamous, non-keratinized epithelium. Everything is written also there, so don't bother to write. Epithelium, stratified, squamous epithelium. Then there is you can see here, acellular layer, which is Bowman's layer. Bowman layer. Okay. Then this big part is your corneal stroma. Okay. So stroma contains collagen fibers. These are the cells in the stroma. These cells you can label as keratocytes. Keratocytes. Okay. Then there is this layer, which is a thin layer, red in color, Duas layer. The Duas layer was the recent discovery, not that recent, but you can say, it was discovered later on. Duas layer. Then there is this another acellular layer, Descemet membrane. And the innermost is your corneal endothelium, which is a single layered structure, single cell. I mean, this is not multicellular layers, single layer, the layer of the endothelial cells. Okay, so this is the gross anatomy. Epithelium, Bowman, stroma, Duas layer, Descemet membrane, endothelium. Now, there are some specific characteristics of each layer which are important to know. They can be asked in exam also. So let's do that one by one. So epithelium, as you saw, I told you, it is a stratified, squamous, non-keratinized. It gives a barrier function to the cornea. So corneal epithelium is a barrier. If the corneal epithelium is injured, then the cornea becomes exposed to the various infectious organisms. So this barrier function is important to prevent infections. So you can write here, this is important to prevent infections. So it acts as a barrier. Then it is regularly regenerated. Okay, so it has got a turnover of the cells. The older cells, they are shed off, the new cells, they come up. From where do they come up? Remember, in the morning, we discussed limbal stem cells of Vogue of palisades. So the new cells, the new epithelial cells are being constantly regenerated. Okay, so these are the points to be remembered. Non-keratinized stratified squamous type of epithelium. It can regenerate. It is constantly regenerated by the stem cells of Vogue of palisades. And it has a very important barrier function when the epithelium is, injured, or we call it as abraded. Just like skin gets abraded, the corneal surface can get abraded. Then the cornea becomes susceptible to different kind of infections. Okay, right? Okay. Then the second layer was the Bowman layer. Okay, the small acellular layer which I showed you. Now, Bowman membrane or Bowman layer, we prefer to call it as Bowman layer because it is not a true membrane. A true membrane is secreted by epithelials, by the cells. Okay. Now, this Bowman membrane is not a membrane of any cells. It is actually the condensed part of the stroma only. Now, since it is not produced by any cells, so once injured, it cannot regenerate. So if the trauma involves the Bowman layer, it will always produce scarring. So this is important to remember. Okay? If the ulcer or any injury involves the Bowman layer, if it is only epithelial layer involved, it will not leave scarring because the epithelium will regenerate. But if it involves the Bowman layer, it will leave scarring of the cornea because it cannot regenerate. So point to remember about Bowman membrane or Bowman layer is it cannot regenerate. That is one thing to remember. Okay, friends, right? Then comes your stroma. So you saw the stroma forms the major part of the corneal thickness. The more than 90% of the corneal thickness is because of stroma. Stroma contains two important things. One, it is made up of collagen fibrils. These collagen fibrils, they are placed in a regular arrangement in the form of lamellae. And these lamellae are responsible for corneal transparency. The cornea has to be transparent like a glass because only then the light will pass through. If there is any opacity or scarring of the cornea, the light will not be able to pass through the cornea. So stroma has these collagen fibrils which are in regular arrangement in the form of lamellae. These lamellae are responsible for the regular arrangement of lamellae is responsible for corneal transparency. Okay, and then I also showed you the keratocytes which produce these collagen fibrils. Okay? Now, if there is injury to stroma, this regular arrangement of the fibrils is destroyed. Okay, the injury to stroma leads to scarring because the regular arrangement of the lamellae is destroyed. Okay, right? Then after the stroma comes that small layer, Duas layer. It is also called pre-descent because this is present before descent. Pre-descent layer. It's very thin, 15 micron thickness, and this is now considered the toughest layer of the cornea. Okay, if there is a one-liner about the toughest layer of cornea, it is your Duas layer. So toughest layer of cornea, Duas layer. Okay. Before the Duas layer, descent membrane was considered to be the toughest layer, but now they have identified that it is the Duas layer which is the toughest layer of the cornea. Though it is very thin, but it is quite tough. Then comes your descemet membrane. Then comes your descemet membrane. Now, descemet membrane is a true membrane because it is produced by the endothelial cells. It is highly elastic membrane. Now, this is the important point. It is highly elastic membrane. When there is, like, you'll be learning very shortly, when there is corneal ulceration, sometimes the cornea can perforate, but descemet membrane is the last to give in. It is very elastic membrane. So it persists as descemetocele. I will tell you what is descemetocele in ulcer. So it resists the perforation till last. So it is highly elastic membrane. And it can regenerate because it is secreted by the endothelial cells. So Bowman membrane cannot regenerate, descemet membrane can regenerate. Then endothelium. Now this is one of the, again, most important corneal layer. It is made up of single layer of hexagonal cells which are uniformly placed. These cells, they contain sodium potassium ATPase pump which help in maintaining the cornea in dehydrated state. It is not star, dehydrated state. Why? What do I mean by this? So try to understand. Dehydrated means, like, cornea is transparent. If the fluid comes into cornea, if the corneal tissue becomes hydrated, it will lose its transparency. Okay. You see cornea, what is behind the cornea? We have done the anatomy now. What is behind the cornea? Anterior chamber, isn't it? And anterior chamber is filled with fluid, aqueous humor. So you can see the cornea is in constant touch with the aqueous humor. So if this aqueous humor, the fluid goes into the cornea, then the cornea will become hydrated. It will not remain transparent. It will lose its transparency. So if cornea will not be transparent, you will not be able to see. So that is the importance of the endothelial cells. The endothelial pump cell, the pump which is there, sodium potassium ATPase, that kind of, removes the excess hydration of the cornea and keeps it in relative dehydrated state. And because of this, I mean, the endothelium is also considered to be most metabolically active because it is constantly working to keep the cornea in transparent stage. Okay, right? Important thing about endothelial cells is they cannot regenerate. Epithelium can regenerate. It is constantly regenerating, but endothelial cells, they do not regenerate. Okay. At birth, you can write here, at birth, the human eye contains 6,000 endothelial cells per millimeter square of cornea. At birth, the figure is around 6,000. Throughout our life, we keep on losing these cells. An adult will have about 2,500 to 3,000 cells per millimeter square. If the number of the cells drops to less than 500, there can be certain corneal diseases, there can be the trauma to the cornea, so that the further endothelial cell damage occurs. If the endothelial cells, they drop less than 500 cells per millimeter square, the person will have what we call as endothelial decompensation, and there will be corneal edema because cornea has become hydrated. So that is the importance of the corneal endothelium. Okay, this is important to understand certain corneal diseases also when we will be talking about them. So endothelial cells are very important. They are most metabolically active. So this can be your one-liner question. They are made up of single layer of hexagonal cells. This can be your question. They cannot regenerate. We lose the corneal endothelial cells throughout our life. If the cells, they become less than 500 cells per millimeter square, the person can have endothelial decompensation. The cornea will become hydrated. It will lose its transparency. It will lose its transparency. Hydration of the cornea means loss of transparency. Loss of transparency of the cornea, which we do not want. Right? Okay. Right. So coming to the corneal transparency, let's kind of compile all the factors which are responsible for corneal transparency. So sometimes this can be asked as a question, the factors responsible for the corneal transparency. So what all we did, let's compile that. So I told you regular lamellar arrangement of collagen fibers in stroma. They have to be regularly placed. No kind of crisscrossing. They have to be regularly placed, not crisscrossing. So that is responsible for the corneal transparency. The intrastromal pressure, like, stroma, it is making up 90% of the cornea. It has its own pressure. So that prevents any fluid coming into the cornea. Okay, intrastromal pressure prevents any fluid coming into the cornea. So that is also important. The pump function of the endothelium, the sodium potassium ATPase pump. Similarly, the barrier function of the epithelium and endothelium. So both these layers, they also act as a barrier. So no fluid coming from outside, no coming fluid of the aqueous humor going into the cornea. And then avascularity of the cornea. So if there are blood vessels, so any tissue which has blood vessel cannot be transparent. So that is why the cornea does not have any blood vessels. That is also helping us, keeping it transparent. Okay. Now the thing is, if the cornea does not have blood vessels, from where it is getting its nutrition? So that is important to know, from where it is getting its nutrition. Surprisingly, the major metabolism of the cornea is aerobic. So it has to have good oxygen supply. The anaerobic conditions, they lead to accumulation of lactic acid. The major metabolism of cornea is aerobic. So it is getting its oxygen. It's getting its oxygen from the air in the precorneal tear film. The cornea is always covered by the tear film, and the air gets dissolved into that air film, and cornea takes its oxygen from there, okay, from the air, right? And the nutrition is from the aqueous humor. That is the purpose of aqueous humor. It gives nutrition to the cornea as well as to the lens, both avascular structures. Okay, right? And then the nerve supply, I told you the sensory nerve of the eye is, so this is a kind of revision also for us. The sensory nerve of the eye is trigeminal nerve. So you must know the cornea is very, very sensitive. The cornea is very, very touch sensitive. If anything comes close to the cornea, our eye blinks, isn't it? Because anything touching the cornea, the corneal sensations are very powerful, because that is a protective mechanism. If something touches the cornea can become injured. So this is a corneal reflex. Anything coming close or touching the cornea, the eye will automatically blink to close. So it is very, very sensitive. Corneal sensations are remarkable, and they are through the trigeminal nerve. They are through the trigeminal nerve. Okay. So these points, they help us to understand the diseases which we are going to discuss very shortly. So this is about the normal anatomy, physiology of cornea. Now moving to next. What are the investigations which help us in diagnosing the corneal diseases. Okay. Now, cornea, as I told you, the main thing is like, the curvature of the cornea. If the changes occur in the curvature of the cornea, in the transparency of the cornea, that can lead to different kind of diseases. So to investigate any such disease, what all we are using, the different investigation, the name of the investigation and the purpose can be important from exam point of view also. Okay. So in corneal investigation, first of all, it is your keratometry. Keratometry, friends. What is keratometry? Now, kerato word is for cornea. Metry means measurement. Okay? So keratometry is when you are measuring the corneal curvature of the anterior surface. Okay? Let me just charge my iPad just for a moment here. Right. So sorry for the break there. Let me take my pen here, just a moment. Okay. So what we are discussing here is the corneal investigations. Keratometry. Kerato means cornea, metry measurement. So measurement of the curvature of anterior surface of the cornea. Okay. And the central part only. So this gives us the curvature of the central part only. Okay? That is your keratometry. Mostly the keratometer which is used is by the name of Bosch and Lomb keratometer. Okay? Then the second investigation which is done is corneal topography. Corneal topography. Now in this, we are able to measure the corneal curvature of entire cornea, entire anterior surface. This was only the central part. Here you are doing the central as well as peripheral part also. So that is why it is called mapping. You can map whole of the cornea of anterior corneal surface. Okay. So difference between keratometry and topography you understood. Keratometry, central part of anterior surface only. Topography, entire anterior corneal surface. So this is based upon a principle of Placido disc. Okay? Placido disc means, if you see this picture, this is for your understanding only. You see these rings. These rings, they are based upon a Placido disc, which was done, which is now also done, but earlier done for the keratometry only. So this corneal topography is based upon the principle of the Placido disc. If the corneal curvature is regular, the rings will be regular. If it is irregular, the rings, they will be irregular. So that used to be the principle of Placido disc, just to let you know. Okay? So this is your corneal topography. Okay, right? Then we have now still better investigation, which is called corneal tomography. Tomography. What is the advantage of corneal tomography? It tells us the curvature of the anterior surface as well as posterior surface of cornea. Okay, topography is only for the anterior surface, This is for anterior as well as posterior surface of cornea. And it is specially helpful in the diagnosis of keratoconus. So this is just to let you know how a corneal tomography looks like. So these are the color codings. The red means high curvature, yellow means high curvature, the blue means not steep cornea. Okay, the curvature more means more steep cornea. The flat areas, they will be blue. So this is how the map looks like. This is just to give you an understanding of how a corneal tomography, the different areas they are seen, anterior surface as well as posterior surface. Okay, so this is anterior surface, this is posterior surface. So you can now examine the cornea all through with the help of corneal tomography. Okay, so three things, just I'm giving you an idea once more. Keratometry means only the central anterior surface curvature. Topography means complete anterior surface. Tomography means that both anterior and posterior surface of the cornea. Okay, so all these three are basically for the corneal curvature. Then there is another important investigation by the name of specular microscopy. Specular microscopy. Now, in specular microscopy, this is to study the corneal endothelial cells. So I just told you about the corneal endothelium, and this is how, when you look through the specular microscopy, the cells, they look like. You know, what we did, हमने अभी क्या पढ़ा था? The regular hexagonal cells. So you can see uniformly placed regular cells like a honeycomb. They look like a honeycomb. Regular uniform hexagonal cells. So specular microscopy gives me the count of the cells and tells me also the morphology of the endothelial cells. Because there are certain corneal diseases in which the cells, they can become low, the morphology is destroyed. So those, they can have like, different kind of signs there. So specular microscopy helps me in study of the corneal endothelium. So, I mean, they can be one-liner questions. The corneal endothelium is examined with specular microscopy. Okay, right? Then another investigation is what is known as pachymetry. Pachymetry is for measurement of corneal thickness. Another one-liner. Pachymetry is measurement of thickness of the cornea. Okay? There are different kind of pachymeter. The ultrasonic pachymeter is the gold standard test. Gold standard means sort of best test. Okay? Right? Pachymetry, corneal thickness measurement. Then there are certain vital dyes. Vital dyes means the dyes which you are like, staining the live tissue there. Okay? So certain dyes, they can be used to stain the cornea and to study the health of the cornea. Two commonly used dyes which are used are, one is your sodium fluorescent dye and one is your rose Bengal dye. Sodium fluorescent dye and rose Bengal dye. Now, let me show you this sodium fluorescent dye first of all. Okay, so the dye actually is orange in color. Okay, you put a drop of the dye in the eye, or there is sometimes a paper strip in the eye. The part of the cornea, like, the part of where the epithelium is abraded or the corneal epithelium is ulcerated, there is no epithelial cells, that part will take up the stain. Okay? So this is the healthy cornea, and this is the cornea where there is no epithelium. So that will take the fluorescent stain. We use a special blue light filter. We call it as cobalt blue filter to see the corneal staining. Okay, so you put a drop of dye, the sodium fluorescent dye is orange in color. You switch on the blue light filter, and if the epithelium abrasion or defect is there, then that will be stained by that area will be stained by the fluorescent. And in blue light, that area will appear green. So you can see this area is appearing green in color in blue light. Okay, right? And the second dye which we use is the rose Bengal dye. So this is the picture of the rose Bengal dye. It is a red color dye. Now rose Bengal dye will stain the dead cells also. The cells are still there. They are not denuded. They are not abraded. But it can stain the dead cell or unvitalized cell also. It can stain the mucus, and it is specifically used for the dry eye classification. Okay, you see, even the conjunctiva cells, they are also stained. So corneal cells as well as the conjunctival cells are stained. So rose Bengal dye staining can be used for the diagnosis of dry eye also. So this can be an important point here, right? So what can be your questions here? The dyes, two dyes which are used for the corneal staining. One is your sodium fluorescent. Second is your rose Bengal. The fluorescent tells us the areas of epithelial abrasion. That is where there is ulcer, no epithelium. Okay. The rose Bengal tells us where even the devitalized cells or the diseased cells are. And it also helps in diagnosis of dry eye. Okay, is that all right? Okay. So this was your cornea, important points in anatomy, important points in the physiology, investigations which we do for cornea, the test which we do for cornea. Okay, so now we will be proceeding to the different diseases of cornea, most of which are very high yield topics. Before that, I think we can take a tea or coffee break and then come up recharged to learn about cornea. Is that all right? Okay, so friends, let's have a break for 20 minutes. Okay, this is not a lunch break now. This is the tea break now. And I see you back in 20 minutes. Okay, right. Thank you. Welcome back, friends. Welcome back, and let's continue with cornea. Before the break, we just finished the basics, and now we are going to discuss the diseases of cornea. So diseases of cornea, your very high yield topic, question coming in every exam. Cornea, 2 to 3 questions in every exam. And the topic which we are going to discuss now, corneal ulcer, has been favorite of examiners, always favorite of examiners in some way or the other. Okay, so all set here, friends, all set here. Okay, so let me now begin with the infective keratitis, corneal ulcers. So infective keratitis means, we discussed in the beginning, itis means inflammation. So when it is the inflammation of the cornea, that is keratitis. And when this inflammation is secondary to an infective process, that is due to some infective organism, then it is infective keratitis. So what happens when there is inflammation of the cornea? The inflammatory cells will come. Now, inflammatory cells, they appear as infiltration of the cornea. So we have just read that the cornea is a transparent structure. So when there is infiltration of inflammatory cells, that will lead to loss of the transparency. The cornea will have those kind of inflammatory exudates there. Now, the process of inflammation also leads to necrosis of the tissue or sloughing of the tissue. So keratitis means there is infiltration of the inflammatory cells and necrosis of the healthy tissue. So that is your keratitis. And when this keratitis is associated with an epithelial defect, epithelial defect means, I told you, the epithelial layer. When the epithelial layer is denuded, it is abraded, then it is called ulcer. In the skin also, or over any membrane, when the overlying membrane of a tissue is gone, we call it as ulceration. So here also, when there is inflammation, there is necrosis, and there is an epithelial defect, we call it as ulcer. Now, the infections in the cornea, they can be most commonly due to 4 types or category of organisms. It can be bacterial, causative agent can be bacterial. It can be fungal. It can be viral. It can be protozoal. So the causative infective organism can be bacterial, then we'll call it as bacterial keratitis or bacterial corneal ulcer. Fungal, then we call it as fungal keratitis or fungal corneal ulcer. Viral keratitis or viral corneal ulcer. And protozoa, depending upon which organism it is, it's called that. Okay. Now, what happens, what are the risk factors and what are the causes and symptoms of corneal ulcer? Now, some things are common to all types of corneal ulcer, and then there are some specific features of each one of those which we will be discussing. So first of all, how does cornea becomes predisposed to injury? So I told you the most important barrier to prevent corneal injury is corneal epithelium. The most important barrier is the corneal epithelium. So whenever there is injury to epithelium, which can occur with anything, it can occur due to a mechanical trauma, it can occur due to poor health of the ocular surface, it can occur due to use of contact lenses, it can occur due to steroid misuse. It can occur due to the immunosuppressed states of the body. So whenever the epithelial barrier function is compromised, the risk of infection to the cornea is increased. So that is the basic funda there. Okay? So predisposing factors or the risk factors, they are associated with poor health of the corneal epithelium. So it can be the corneal abrasion. Abrasion means the corneal epithelium is denuded due to any reason. It can be severe dry eye. If you are using steroid eye drops, steroid abuse, or anesthetic abuse, the corneal sensations will be lost in the anesthetic use. So you will not even know that your epithelium is injured. Okay. Chronic blepharitis. Blepharitis means the lids. If there is inflammation of the lids, that can rub upon the cornea. Tracheasis, misdirected lashes, I told you, can rub upon the cornea. Bullous keratopathy. Bullous keratopathy is a condition in which there are, vesicles or epithelial layer becomes bullous. Okay? There are epithelial bullae which can rupture and they can cause corneal ulceration. Or immunosuppression, diabetics, the people suffering from HIV or immunosuppressants, they are always predisposed to corneal infections. Okay? Now, the most common risk factor in the history, which you have to look for when there is a clinical case scenario, because we have to correlate our study with how the question is going to come in the exam. So in the case history, when there is history of trauma followed by signs and symptoms related to cornea, there is possibility that they are talking about corneal ulcer. Okay. So in developing country, the most common risk factor, in countries like India, the most common risk factor is trauma to the eye. So trauma to the eye is the most common risk factor. So this is an important point for development of corneal ulcer. Okay. Then in developed countries, because the trauma chances are less, people are more, in the use of having contact lenses in their eye. So in those places, the use of contact lens is the most common factor for countries like US or developed world. Okay, right? So for India, you have to remember that trauma is the most common risk factor. Now, what are the symptoms of the corneal ulcer? How the patient will present to you, what you will be looking for in the clinical case scenario. So again, 5 symptoms. The cornea, because cornea is a very sensitive eye structure, the symptoms, they will always be very, very severe. Okay. So this is the difference between conjunctivitis, because both they can cause red eye. There will be red eye in both. Conjunctivitis also, corneal ulcer also. But remember, in conjunctivitis, what I told you, mild discomfort. Discharge can be there, photophobia can be there, but usually not very severe pain, just grittiness, and vision usually is not affected in conjunctivitis. But here in cornea, the symptoms are much more. So patient will have severe photophobia. There will be red eye. There will always be pain. Okay. So corneal ulcer will always have pain. There will be decreased vision because cornea does not remain transparent whenever there is ulcer. And there can be discharge. So a painful red eye with discharge, with decreased vision, keep in mind it can be a case of corneal ulcer. Okay, right? Now, these symptoms are the common symptoms. Now we are going to go for the signs, and the specific signs and symptoms, they depend upon the type of the corneal ulcer. Now, please concentrate here. This is important topic for you because The questions based upon the typical sign and symptoms of corneal ulcers are very, very common, friends, very often asked, very high yield. So let us discuss bacterial keratitis or bacterial corneal ulcer. Bacterial keratitis or bacterial corneal ulcer. So first of all, one-liner can be what is the most common cause of or causative organism of bacterial keratitis. If they are talking about India, when they have not mentioned anything, talk about India. So that will be pneumococcus. Pneumococcus. Okay. So most common organisms, always remember, for bacterial corneal ulcer, pneumococcus. Worldwide, it is Staph aureus. In India, pneumococcus is more common. Okay. Now, what are the signs and symptoms of a bacterial corneal ulcer? So symptoms I have already told you: painful red eye, decreased vision, photophobia, discharge. Now, okay, so I will first you come to the pathology of the corneal ulcer and then we will talk about the organism. So what happens? So come to this figure, beta, in which there is this pathology of corneal ulcer. Pathology of corneal ulcer on page 51, right? Now, let us see how the ulcer progresses and how the, what is the natural course of the ulcer. So first of all, the epithelium is injured. Okay. So when the epithelium is injured, now this is for your understanding here. So when the epithelium is injured, the polymorph inflammatory cells, they will come. Okay. So this is the ulceration which has happened. Now the polymorph cells, they are coming and they are causing an infiltration here. Okay. The ulceration progresses. Okay, it goes from superficial to deep. It is progressing. Now it will depend upon the severity of the organism, that how deep it goes. So there will be necrosis. Okay, so this is necrosis is happening, the loss of the tissue there, right? So now there can be two things. One is, if it keeps on progressing, it goes more deep, more deep, more deep, and it can cause involvement of the whole thickness of the cornea. Then it can cause perforation. If the stromal necrosis keeps on progressing, the cornea can slough off. It can cause corneal perforation. Okay. The second thing is that the body's immunological mechanism gets better of the infection, okay, and the inflammatory process stops there. So the blood vessels, they come in that area, they start the healing process, but healing process will always lead to fibrosis or scarring, and you will be left with a corneal opacity. You will be left with a corneal opacity, but acute infection goes away. Okay, so these are the two things which can happen here in the natural course of the corneal ulcer. Okay? So it starts with the epithelial injury. Inflammatory cells will come. There will be ulceration. There will be stromal necrosis. The depth of the ulcer will depend upon the severity of the infection. It can go into two directions. One is that stromal necrosis is progressively occurring. It causes impending perforation, means the cornea becomes very thin or may actually perforate. That is corneal perforation. Okay, so that will have its own complication. We'll be discussing. Once there is corneal perforation, it is a complicated ulcer. What happens there, I'll be just shortly telling you. The second is, the body defense mechanism takes better hold of the infection. The inflammatory process stops. The vascularization comes. The healing process starts. But healing is always associated with fibrosis, because the stroma never remains the same. It will have scarring. It will leave opacity. But at least the infection is controlled. Okay, so we can have a corneal opacity as an end result of the corneal ulcer, or if it becomes complicated, it can complicate to corneal perforation and so on. We will discuss. Okay. So here I told you everything starts from the epithelial injury, but there are few organisms which may cause the ulcer through a normal healthy epithelium. They can penetrate through the healthy epithelium also without any predisposing injury. Okay, so what are those organisms? That list we should know. So that is mentioned on page number 51, just above there. Organisms which can penetrate intact cornea. So this is an important list. It can come as an one-liner question. Now, in case of these organisms, even if when there is no epithelial injury, they can involve the stroma, cause inflammation and necrosis and all that stuff. Okay, so how to remember these? There is a mnemonic as lunch. So we just finished our lunch long back. We also had a coffee. So as lunch, that can be mnemonic to remember this. A stands for acanthamoeba, S for Shigella, L for Listeria, U is nothing, N Neisseria group, which involves both gonococcus and meningococcus, C for Corynebacterium diphtheria, and H for Haemophilus. Okay, so these organisms, so that is why gonococcus, remember I was telling you since the conjunctivitis that it can involve the intact cornea, and these are the list of the other organisms which can penetrate the healthy cornea. If body's immune system is weak, they can cause the corneal ulcer. Now, important thing is because Pseudomonas is considered to be a very virulent organism, but please remember Pseudomonas cannot penetrate intact cornea. So this is a point to be remembered. If Pseudomonas is in the question and they're asking about organisms which can penetrate the intact cornea, please don't mark Pseudomonas, because Pseudomonas is virulent. It is a virulent organism, but still it cannot penetrate intact cornea. Okay, right? So bacterial keratitis, we have done the pathology, what can happen. Now, what can be the clinical features? Coming to page number 52, beta. What can be the features of the clinical features of bacterial keratitis or signs of keratitis? Okay, so let me read it out, then I will mark on the image and you will get to know. The bacterial keratitis will have wet infiltrate. Infiltrate, I told you, the exudates or the inflammatory cells which they collect on the within the cornea. Okay, so this will have a wettish appearance, wet infiltrate. Okay, the ulcer margins will be well defined. There will be a boundary, well defined boundary of the ulcer margin. There will be a hypopion. So what is hypopion? Please write it down. The pus cells or the inflammatory cells which accumulate in the anterior chamber, that is called hypopion. Okay, so this is the term which has come here for the first time. Hypopion. What is hypopion, friends? Pus cells in the anterior chamber, they are called hypopion. Now in corneal ulcer, there can be hypopion, but in bacterial one, this hypopion is sterile, that it does not contain bacteria, and it is mobile. Mobile means you change the head position. It is fluidy, it moves. Okay, right? There is early vascularization. The vessels, they start coming on the cornea. Cornea doesn't have vessel, but when there is ulceration, the vessels of the conjunctiva or on the limbus, they try to come onto the cornea. And perforation is common. If the bacterial infection is severe enough, the chances of having a corneal perforation is very common. So these are the features of the bacterial keratitis. Okay? So let me show you. This is the picture of corneal ulcer. Now please have a look here. This can come as an image-based question. So how you will identify the corneal ulcer? Let's see the features better. So you see this red eye, the eye is congested. Okay? The cornea is hazy. What you are seeing over here, this is the area of the corneal ulcer. Okay? And as you can see, this has well-defined margins. And it has these whitish lesions are the inflammatory infiltrate. This whitish lesion is inflammatory infiltrate. It's appearing moist, isn't it? Look here nicely. This is the collection of the pus in the anterior chamber. That is hypopion. The collection of the pus in the anterior chamber, that is hypopion. Okay? As you notice, these blood vessels, they are coming here. They are now coming to kind of like, bring in they are a part of the healing process actually, but vascularization ultimately will lead to opacification only, right? So these blood vessels, they are coming there. This hypopion, as I told you, does not contain any bacteria. It is sterile and it is mobile. If the disease keeps on progressing, the chances of perforation, like sloughing of the cornea happens and the cornea can perforate. The sloughing of the cornea happens and cornea can perforate. Now, these are the features of bacterial corneal ulcer. Okay, right? Now, how would you treat? How would you treat the bacterial corneal ulcer? Now, the management is in the form of antibiotics. The management is in the form of antibiotics. Intensive antibiotic eye drops are to be given. Okay? So before that, you confirm the diagnosis also, because corneal ulcer, we are saying that it is a bacterial ulcer based upon the clinical features. You start the treatment, but at the same time, you confirm the diagnosis also. So how do we confirm the diagnosis? The diagnosis is confirmed by taking corneal scraping. Okay, a part of the cornea is scraped to get the tissue, and that tissue is subjected to the smear, that is staining with the gram stain, as well as culture. The bacterial culture is done on the blood agar. Okay, so you wait for the definitive diagnosis, but at the same time, you will start the patient on intensive antibiotic therapy. Okay, we can use fortified antibiotics like fortified cefazoline or tobramycin or fortified vancomycin, or even broad spectrum fluoroquinolones. So these are the commonly used fluoroquinolones. These are the commonly used antibiotics. We are using the topical eye drops. At the same time, we use cycloplegic. Cycloplegic, I told you which cycloplegic we are using, atropine. And then we give vitamin C orally to promote the healing. We give lubricant eye drops for the comfort of the eye. Two important things in the bacterial corneal ulcer: no patching. Never patch the eye because it can aggravate the infection. And secondly, no steroids. Please write it down. In the treatment of the corneal ulcer, no patching, no steroids. Okay, this is an important point for exam also. No patching, no steroids. So you got an idea? You had a patient which is having symptoms of corneal ulcer. You saw the patient. You noticed what signs are there. You confirm the diagnosis by doing corneal scraping, and you start the patient on treatment. Okay? The treatment includes topical antibiotics. It will include cycloplegic like atropine eye drop, vitamin C, lubricant. but two things which are contraindicated: no patching, no steroids, because both of them, they can aggravate the disease. Okay. Now, I told you that you are treating the ulcer. So ulcer can go on now into the healing phase, but sometimes the ulcer does not heal. It may be that the patient never come for the treatment, or even sometimes despite the treatment, the ulcer does not heal. Then what happens? Now, when the ulcer does not heal, it becomes a complicated ulcer. The ulcer is not healing, even sometimes after treatment. Then it becomes a complicated ulcer. We call it as non-healing ulcer. Now, why there can be non-healing ulcer? Either the organism is very virulent, okay, or the healing process is not optimal. So we try to help in healing of the ulcer. How can we do that? You can use a bandage contact lens. A bandage contact lens means you cover the cornea by a contact lens. You cannot patch, but you can cover it by a contact lens so that healing of the ulcer is promoted. Okay, because every time you blink, your eyelid is touching the cornea. Every time you blink, your eyelid is touching the cornea. If there is corneal ulcer, so this blinking can also lead to non-healing ulcer. So you cover the cornea by the bandage contact lens. Okay. We can also do epithelial debridement to remove the slough, to remove the dead slough. Dead cells are there. They are not letting the healthy epithelial cells come. So you scrape the epithelial dead cells so that healthy cells, they grow. Okay. For the same purpose, we can do chemical cauterization, that you apply a chemical, which is TCA. It is also called trichloroacetic acid you can use. You can also use carbolic acid, beta. Okay, so you can write these points. You can use a drop of carbolic acid or trichloroacetic acid. That also removes the dead slough and helps in bringing the healthy epithelial cells. Okay. Sometimes there can be a retained foreign body in the eye, some dust particle, something which is not letting the healing occur, which can be embedded on the lid, or sometimes it can be even misdirected eyelash. So if there is even trichiasis, you have to remove those eyelashes. So you remove the causes of the non-healing ulcer, you help in promoting the healing of the ulcer. So that is one thing. Okay. Sometimes despite this, the ulcer does not heal and the stromal necrosis is progressing. So that will lead to impending perforation. Impending means which is about to happen. So, I told you the descemet layer is a very elastic layer. Now you see here, look at this figure. Now these figures are for your understanding better. Okay, so these images are to understand the different stages of ulcer, because they will make a good visual impression in your mind. So you see, this is the normal looking cornea, and this part of the cornea is so thinned out because of the progressive necrosis. So this is thinning. Now this type of ulcer can perforate any time. What happens? The descemet membrane, you see here, the descemet membrane is very elastic. The descemet membrane is so elastic that it resists the perforation till long. It kind of comes out through that area like a blister. Okay, so we call it as descemetocele. We call it as descemetocele. But this descemetocele can ultimately rupture. Patient coughs violently, or some injury happens. So this when descemet membrane ultimately gives away, you notice here, beta, the perforation has happened. The perforation has happened. So this is how the corneal perforation occurs. Now, when corneal perforation occurs, what will happen? Can you tell me what will happen when corneal perforation occurs? The fluid of the interior chamber, the aqueous humor will come out and the iris will collapse to cornea, isn't it? The interior chamber will collapse because the aqueous flows out and the iris now becomes adherent to the cornea. Okay? So have a look at these figures, how a progressive ulcer moves. There is a lot of stromal thinning. Initially, there is desmetocele, but ultimately desmet membrane also gives away. Then comes the corneal perforation, the fluid, the aqueous fluid comes out, and iris now comes through that perforation because now it is in touch of the cornea. Okay. Now at this stage, there can be the formation of pseudocornea because iris has plugged that area. Okay. Those exudates, they become organized. That is not a healthy cornea tissue. We call it as pseudocornea. Okay. So that area is now covered by a pseudocornea, which are the organized exudates, organized inflammatory exudates. Okay. So this is when the ulcer is becoming complicated. It is not healing. Necrosis, perforation, iris prolapse, pseudocornea formation. Okay. If the patient comes to you in the stage of impending perforation, impending means like here, when thinning is there or when desmetocele is there. So at this stage, you can still help the patient. How can you help the patient? What we can do, beta? The treatment of impending perforation is, you can, if it is a very small area, you can again give bandage contact lens. Ask the patient not to strain, violent coughing, sneezing. Don't do that. Okay? Give anti-glaucoma treatment. Anti-glaucoma treatment is to decrease the IOP, intraocular pressure, the pressure of the fluid in the eye. So you give drugs so that the inner pressure of the eyeball is decreased and the ulcer does not perforate. Okay. Or we can apply what we call as tissue adhesive. There is a glue by the name of cyanoacrylate glue. That glue, this is a picture to show you how the glue looks like for your understanding. This glue has been, this thing which you are seeing is the glue has been applied on the surface of cornea, not the physical glue. It is a specific tissue adhesive, cyanoacrylate glue. When it comes in contact of cornea, it solidifies and it plugs the perforation. Okay? So cyanoacrylate glue can be applied to plug a small perforation till the time healing occurs. Okay. Do you notice anything in this picture here, beta, in this image here? Anything very remarkable? See, such a big hypopion. Can you identify the hypopion now? How the hypopion looks like? Okay. So this large pus in the interior chamber. So now when you see this kind of pus in the interior chamber, in any image, you can identify this is hypopion. Okay, right? Okay, so we were discussing the treatment of the impending perforation. And the last, if already perforation has occurred, then we have to do therapeutic keratoplasty. So we will be discussing about the keratoplasty. Keratoplasty means corneal transplantation. Okay, so if the perforation is big, you have to maintain the structural integrity of the eye. You cannot let the eye, with having a perforation just like that only. So we apply the corneal transplant. This type of corneal transplant is known as therapeutic keratoplasty. Okay. Now for your exam here, beta, they can ask you the use of the cyanoacrylate glue. Okay. So please remember, this can be asked as a question. tissue adhesive or cyanoacrylate glue is used for impending corneal or small corneal perforations. And for big perforations, you do therapeutic keratoplasty. Okay, right? So this we have discussed about your bacterial ulcer. So you got an idea, bache? But what I told you, how the bacterial ulcer is going. The normal treatment of bacterial ulcer will be with the help of the topical antibiotics, cycloplegic, no patching, no steroid. But sometimes the ulcer can become complicated. It is just not healing. So there can be different causes. You assist the healing by different methods, bandage contact lens, epithelial debridement, chemical cauterization, etc., etc. Sometimes still it is not helping and the necrosis keeps on progressing. Then it can be a stage of impending perforation, that the perforation is about to happen. There is a lot of thinning there. The descemet membrane is holding on. It can produce a desmetocele, but ultimately it perforates. When it perforates, the iris comes from behind. There is iris prolapse. It plugs that area and there can be pseudocornea formation. Okay. In the stage of impending perforation, we can help a patient by giving again bandage contact lens, by giving anti-glaucoma treatment. We can give cyanoacrylate glue, which is a tissue adhesive. But if the perforation is very large, the cornea is completely sloughed out, you have to do cornea transplantation, that is therapeutic keratoplasty. Okay, so this is about bacterial corneal ulcer. Now, from exam point of view, few important things which you must know, right? One is like, I told you pneumococcus is the most common cause of the ulcer. Now, the pneumococcal ulcer is also called hypopion ulcer. Okay, so this can be used as a one-liner. Please mark it. The ulcer caused by pneumococcus is called hypopion ulcer because it is nearly always associated with the hypopion. In other ulcers, the hypopion may or may not be present. But in pneumococcal, it is always associated with hypopion. So it is called hypopion ulcer. Sorry. And then another, write it here, coming back to the page number 54, pneumococcal and hypopion ulcer. So another feature of this is the shape of the ulcer is also called Serpens ulcer. This can also be asked as one-liner question. Like a snake, the ulcer kind of like, involves the cornea like a snake-like fashion. So these two words, hypopion ulcer and serpent ulcers, they are features of pneumococcal ulcer. Okay, beta? They are features of pneumococcal ulcer. Now, then Pseudomonas. So I told you Pseudomonas is a very virulent organism. Okay. Now it is so virulent that it causes very rapidly progressive ulcer. And within 48 hours only, the patient can have corneal perforation. Okay. So that is the point about the Pseudomonas, that it can very rapidly go to the stage of corneal perforation. And it is also most common cause of keratitis in contact lens users. So again, a question for you. Okay. So what I told you, Pseudomonas is a very virulent organism. It can rapidly lead to the perforation. At the same time, this is also one of the most common cause of ulcer in contact lens users. The most common organism. Clear, bacha? And the pneumococcal, you will remember two words about pneumococcal: hypopion ulcer, serpent ulcer. Hypopyon ulcer, Serpent's ulcer. Okay, friends? Okay. Now, something more about the ulcer. Ulcer is not going to leave us very soon. Okay. So what happens, as I told you, even when the healing is occurring, there is always some sequelae. The corneal ulcer will always leave some sequelae there. Sequelae means some, end things there. Just a moment. So it will always leave some sequelae there. So what can be the sequelae of corneal ulcer? So number one is your corneal opacity. So because once the Bowman membrane stroma is affected in corneal ulcer, the healing occurs, but it always leaves scarring. I have already told you. Now, because it always leaves scarring, it's going to leave a corneal opacity. That area is no longer transparent, that becomes opaque. Then it can lead to the formation of adherent leucoma. I'll just tell you what is adherent leucoma. And it can lead to the formation of anterior staphyloid. Okay. Now, let's concentrate here, beta. Depending upon the depth of the opacity, how much area of the cornea or how much depth of the cornea is involved, there are 3 types of corneal opacities. Okay. These 3 types are nebular opacity, macular opacity, leucomatous opacity. Okay. So clinically, how we differentiate, nebular opacity is most superficial. Through the opacity, you can see the iris details. So it is just very superficial opacity, but it is most visually disturbing because it causes scattering of the light. If the cornea is not clear, the light scatters. If you see, must have seen, like, if there is a transparent glass, if the glass is broken, have you seen those scattering lines within the glass? So similarly, if the cornea is not clear, when the light falls on the cornea, it gets scattered. So most superficial opacity, but it causes most visual disturbance. That is your nebular opacity. The second is macula. So cornea, if it is transparent, you can see the iris through it. But if the opacity is macular type, you can see iris, but the pattern of the iris or the iris details will not be visible. Okay. And leucomatous, leucoma means white. The leucoma, the word leucoma means white. That area is completely white. That no light is passing through that opacity and iris is not visible. So this is how you clinically judge whether the opacity is nebular, macular, or leucomatous. Okay. And if I want to show you like here, so if less than 1/3 of the corneal depth is involved, okay, if less than 1/3 of the corneal depth is involved, as in figure A, so A is your nebular opacity, less than 1/3 of the corneal depth. Okay. Now here, more than 1/3, but less than half. Okay. Less than half, more than 1/3 is involved. Then it is B, your macular opacity. So B is corresponding to macular opacity. If more than half of the depth of the cornea is involved, that is C, which is your leucomatous opacity. Okay. And look at this figure D. The whole of the cornea was involved and the iris is now adherent because it came and plugged that area. Now that iris is adherent. So this kind of opacity is called adherent leucoma. Adherent leucoma, that is iris, you can write here, iris adherent to opacity. Okay, so these are these terms, beta. Sometimes they can be asked in the one-liner questions. What is nebular opacity? Superficial, visually most disturbing. Macula when less than half depth is involved. Leukomatous, completely opaque, white opacity, more than half. Adherent leukoma means the iris is adherent to the opacity. Okay. So all these, they can happen depending upon what was the depth of the original ulcer. Have a look at this figure here. Figure 6.1 for adherent leukoma. Have a look at the figure here, friends. So you see here, this is a healed ulcer. Now this is for your understanding. Whatever theory, whatever words I have been throwing at you, this is what you see clinically. Okay. This patient must have had an iris, the corneal ulcer, which must have perforated. And now you see the ulcer has healed, but you notice this opacity, white opacity. You cannot see the iris through that opacity. You see this vascularization, which is now coming on to cornea. The healthy cornea has no blood vessels, but this opacity has vessels here. And you see this is the pupil, but here this iris tissue is adherent to the opacity. So this is what happens in a perforated corneal ulcer. After that, the infection heals up, inflammation heals up. The patient has this kind of picture, which is called adherent leukoma. Okay, right? Then there is another thing which can happen, and the question also has come here. Now this here, within the figure, something is written disciform keratitis. Please ignore this. Ignore this one, please. This figure is of anterior staphyloma. This figure is of anterior staphyloma. Okay. Now this image was asked in one of the past exams. So please look at this image. This can be image-based question. Please mark it, beta. This can be image-based question. Ignore what is typed on the figure, that disciform keratitis is wrongly printed there. Now, what do you see here? So have a look at the image. You can see this opacified cornea. The cornea is opacified, whole of it, and it is bulging forward, isn't it? It is bulging forward. So bulging like staphyloma. Staphyloma means the bulging, okay? And this is not a healthy corneal tissue. Okay? This is the, pseudocornea or sloughed out cornea. It is an example in which there was a very severe ulcer. The cornea got completely necrosed. Now it is covered by a pseudocornea. But that pseudocornea is not strong enough to maintain its shape. It's bulging forward. And it also has iris tissue incarcerated, because when perforation happens, the iris goes and becomes incarcerated with it there. Okay. So this is called anterior staphyloma. If there is a figure like this in which there is opaque, corneal tissue, which is actually not the corneal tissue, it is bulging forward. This is your anterior staphyloma, which is a sequelae of complicated corneal ulcer. Okay, so you can write here the anterior staphyloma. What is, you can say the definition of anterior staphyloma? It is ectatic. Ectatic. Ectatic means bulged out. It is ectatic pseudocornea. Ectatic pseudocornea with incarcerated iris. Ectatic pseudocornea with incarcerated iris. It is a sequelae of perforated corneal ulcer. Okay, so not every perforated corneal ulcer will produce anterior staphylomas, but very severe ones, they can have this kind of picture. Okay, so in the exam, what was the question that they had given this image that you can see it's a child's eye actually, that a malnourished child is brought by mother with this image. What is the diagnosis? So what is the importance of the malnourished word there? Because it means the child did not have the good immunity. The malnourishment will lead to an immunosuppressed state. It means the child was having a complicated ulcer. And from the figure, so please get this figure imprinted in your brain there. Ectatic pseudocornea with incarcerated iris is anterior staphyloma, and it is sequelae of perforated corneal ulcer. Okay, friends. So this is how your ulcer can lead to one of the sequelae here. Okay, right? So this all we discussed was more typical of bacterial corneal ulcer, because in the beginning only I told you the corneal perforation is common in bacterial corneal ulcers. Okay, so this is classical clinical features, history, progression, management of bacterial corneal ulcer. Now we are going to move on to the second type of the corneal ulcer, which is fungal. Okay, let's move to page 55, Beta, and let's discuss the fungal corneal ulcer. Now, in different type of ulcer, certain features they remain same, and then there are certain specific characteristics. Okay. Now, fungal keratitis, let me tell you in the beginning only, it is very, very high yield topic for your exam. Fungal keratitis, very, very high yield topic for your exam. The question has been coming in the last, I think, 4-5 exam. One question on fungal keratitis in some form has been coming. Okay, so please concentrate here. Now, fungal keratitis means the infection is caused by a fungus. What is the most common cause? The most commonly, it is your filamentous fungi, aspergillus, and fusarium are considered to be the most common cause. Okay, filamentous fungi are more common. Okay, then in immunocompromised patients, like diabetics, HIV patient, immunosuppressed patients, the candida can be one reason, but mostly it is the filamentous fungi, aspergillus or fusarium. Now, this is a very important point here. Trauma with an organic or vegetative matter. Beta, please put like 3-4 stars here. If in the history, please listen to these words carefully. If in the history, there is a history of trauma with organic or vegetative matter. What do I mean by organic or vegetative matter? Some branch of a tree, the tree twig, a person who is a farmer, who is working in the fields, he gets injured. Injury by some animal tail. So injury by a leaf. So this is your vegetative or organic matter. So if in the history, this risk factor is typically told to you, it means they are talking about fungal corneal ulcer. Your half of the diagnosis is confirmed with just this history point in the question. So because case scenario question is very common for this particular topic, please mark it. Trauma with organic and vegetative matter. If that point is there in the history, it's your fungal corneal ulcer. Okay. Then what other features will tell you that it is a fungal corneal ulcer? There are some specific features. Let me first tell you the features, then I will show you, describe you on the figure. So please read out, let's read out these fungal ulcer features. The dry, raised infiltrate. The infiltrate or inflammatory cells, they are appearing raised and they are dry looking. They are not moist or necrotic as I told you in the bacterial ulcer. Okay. The ulcer has ill-defined margins like feather. There is no clear-cut boundary. Ill-defined margins, feathery margins. Very, very important, satellite lesions. They are the hallmark of the fungal ulcer. There is a main ulcer and small satellite ulcers, satellite lesion. The hypopion is very large, like a dome. It is non-sterile. Non-sterile means that it contains fungal hyphae. And it is fixed. It is not mobile. Vascularization and perforation are uncommon. Now, this is in contrast to bacterial ulcer. So I told you a long story of bacterial ulcers, how the vascularization occur, corneal perforation occur. These symptoms are less common in fungal keratitis. Okay, the perforation is less common. So the specific features are dry raised infiltrate, feathery ill-defined margins, satellite lesions, very, very important, satellite lesions, a large non-sterile hypopion because it contains fungal hyphae and which is fixed. Okay, now come to the figure, beta. Now come to the figure. Again, this figure can come as image-based question. It had come in the previous exam. Now these features, they again should be imprinted in our brain, what I'm talking right now. Fungal keratitis. Okay, so you see, have a look here, follow with me. Now this is the ulcer area. It is appearing raised. Okay, and it is dry. It is as if something is like, dried exudates are there. Okay? You see the margins. The margins, they are so ill-defined. I don't know whether the ulcer is finishing here or here. Feathery margins, we call it as. Okay. And then if you notice, am I enlarging the picture? These small lesions here. These are called satellite lesions. These are called satellite lesions. So there is a main ulcer and then like a satellite, like moon is a satellite of earth. So these satellite ulcers are there. Okay. A very large hypopion, dome shaped, which is like, fixed and non-sterile. So this can be image shown to you with the case history. What will be the case scenario? A person or a farmer comes to you with a history of injury with the leaf. Following that, he had painful red eye and decreased vision. On examination of the cornea, satellite lesions are seen. What is your diagnosis? So you see all these words here: farmer, injury with leaf, satellite lesions. They all point to fungal corneal ulcer. The last time the question was, they had marked an arrow to the satellite lesion and asked for name this lesion. So this will be satellite lesion. Okay, right? So this is your fungal corneal ulcer. I have spent quite a time here because this question is very, very important. Dry raised infiltrate, feathery margins, ill-defined satellite lesion, trauma with organic and vegetative matter. Diagnosis is fungal keratitis. Okay, right? Now, how will you manage? So, the overall management remains nearly the same. We will confirm the diagnosis by doing corneal scraping. For fungus, we can either do KOH mount or we can use Ginsa staining. Okay, we can use Ginsa staining. The culture will be done. The culture will be done on seborrheic dextrose agar. Okay, so you do the corneal scraping and you subject them to wet KOH mount or Ginza staining, and you do the culture on seborrheic dextrose agar. The anti-infective agent which you will be using here, you will be using the antifungal because it is the fungal keratitis. So the drug of the choice for filamentous fungi is topical netamycin. This can be asked as a question. For filamentous fungi, the drug is topical netamycin. For candida, we can use nystatin ointment or amphotericin B. Sometimes the infection is quite deep, then we can give oral antifungal also. Okay, friends, right? So, are you all clear about the fungal keratitis? Please revise these features, risk factors, the figure of fungal keratitis very, very thoroughly, very, very thoroughly. And the differences between bacterial and fungal. Bacterial, wet infiltrate, well-defined, hypopion is sterile. Fungal, dry looking, raised infiltrate, feathery margin, satellite lesion, large hypopion, perforation common in bacteria, perforation uncommon in fungal corneal ulcer. Risk factor, there it can be trauma due to anything, but when there is trauma due to vegetative matter, organic matter, person is a farmer by profession, then most likely it is your fungal keratitis. Okay, right? Okay, let's take a deep breath and move on to the next type of the corneal ulcer, which is your viral keratitis, the infection in the cornea due to virus, viral keratitis. Now, virus, one thing you have to remember, which I have written as the first point here itself, because that is one clinching point for the diagnosis. The viral infection of the cornea always leads to reduced corneal sensations. Okay, I told you the cornea is highly sensitive. You know, the touch reflex, the corneal reflex is highly sensitive. Now, in viral infections, what happens? The corneal sensations are reduced. So this is a very high yield point. So if in the history or in the question statement, they have mentioned that corneal sensations are reduced and there is history of ulcer and all that. So then that tells me that they are talking about a viral corneal ulcer. Okay, right? So reduced corneal sensations will be a feature of viral keratitis. Now, viral keratitis, another peculiarity is the virus can affect the cornea in two ways. What are those two ways? One is by the active infection, just like bacteria and fungus. Okay, so one is by the active infection. The second is the viral antigen produces a kind of immune reaction. Okay, it is not the active infection. The immune reaction to the viral antigen can also cause inflammation. Okay, so these are the two types of the involvement we see. So coming back once again, one feature of the viral keratitis is that it will cause reduced corneal sensation. So that is one clinching point for the diagnosis. The other thing is that either it can cause the active infection, just like the other infective organisms, or it can lead to the immune reaction to the viral antigen, immune reaction. Now, in the viral keratitis, there are two types of the viruses which we are going to discuss. One is your herpes simplex and other is your herpes zoster. Okay. Now, herpes simplex virus. Most commonly, the first infection or the primary infection occurs in childhood, and usually it is in the form of conjunctivitis or with some epithelial involvement, but it is self-limiting. Okay, so primary lesion occurs in childhood and it is usually self-limiting. But then this virus can remain dormant, not dominant, sorry. The virus can remain dormant and it can cause recurrent disease. So when the recurrent disease happens, that is severe and it can have different presentations. Okay, so primary lesion in children is usually mild, self-limiting. The recurrent disease is severe. In the recurrent disease, it can involve only the epithelium. It can involve the stroma also, or it can involve endothelial layer also. Okay, so depending upon the different type of presentation. Now, first of all, see these figures. I'll tell you. So if only epithelium is involved, then it is called punctate lesion. Okay, if only epithelium is involved, we call it as punctate lesion. Now, all these pictures, which stain has been used here, friends? Can you tell me which stain has been used? Why this is appearing green, all these lesions? Because we have used sodium fluorescent stain. I told you the vital staining. We have used sodium fluorescent stain, and since it is an ulcer, it has been stained by the fluorescent dye. We are looking at these lesions under the blue light, and you can see these as green lesions. Okay, so the punctate keratitis, the involvement is like, multiple these dot-like lesions are there. This is your punctate keratitis. The second typical presentation is what is known as dendritic ulcer. Now, this can come as image-based question. So please mark it, image-based question. This can come as image-based question. This has been coming as the image-based question. Okay. Just a minute here. So this can come as the image-based question, dendritic ulcer or dendritic keratitis. So dendritic means appearing like a branches of a tree. Okay, so please see this lesion carefully. So this is the ulcer area. So these are known as dendrites. These dendrites, they contain active virus. The edges, the bulbs, those are called as bulbs. They contain the active virus. So please keep this in mind. Herpes simplex, you will see dendritic ulcer, which contains active virus there. Now, they can ask you to identify this lesion. You can identify this lesion now, dendritic ulcer. Dendritic ulcer. And what is the cause for the dendritic ulcer? Herpes simplex virus. Herpes simplex virus. Now, if this ulcer is not healed, if it keeps on progressing, then it can convert into, come to the figure, next figure here, it gets converted into a geographic ulcer, or what is also known as amoeboid ulcer, right? So you see this lower part is still having the dendritic lesion, and the upper part, the ulcer has now taken a shape of geographic ulcer. So when it worsens. So this is how the ulcer can progress in a case of virus. Okay. So in herpes simplex virus, once again, it can involve just the epithelium when it is the punctate lesion. It can come as a dendritic ulcer. Dendritic ulcer image is very, very important because it was there in the past exam. Okay. Amoeboid ulcer is a complication of dendritic ulcer when it further progresses. Okay? In all these cases, the corneal sensations will be reduced. In all these cases, the corneal sensations will be reduced. And all these three, punctate, dendritic, amoeboid, they are active infection. I have written also in the brackets, they represent active infection with the virus. Okay. Now, the last figure is, so this was actually the misprint which goes up there. So this figure is your 6.20 figure. You can see here. And this figure is, please write it down here, disciform, DISCI, disciform keratitis. This is the image of disciform keratitis. So you see here, if you concentrate, the eye is not that red. There is no epithelial involvement, but there is like, this disc-like area in which the cornea is hazy. It is because of the immune reaction to the herpes. Okay, so there is, this goes here. This is due to immune reaction to the herpes. There is no active infection or epithelial involvement. Right? So please write down the upper three, punctate, dendritic, geographic ulcer, the active infection is there and there is epithelial involvement. The fourth one, disciform keratitis. There is no epithelial involvement. There is no active infection. Okay? This is due to immune reaction to the virus. Immune reaction to the virus. Okay, right? So this is another presentation of herpes simplex in the form of disciform keratitis. Okay, friends? And lastly, the treatment of the herpes simplex keratitis coming next. Now, keep in mind, the treatment will depend upon whether the epithelium is involved and it is active infection or it is immune mediated. Now, when it is active infection, the treatment is antiviral ointment, acyclovir 3% ointment. Steroids are absolutely contraindicated. Mark it as a question point, important point. Steroids, as I told you, any ulcer, any active infection, the steroids are absolutely contraindicated. Bacterial, fungal, viral. In viral, if you give steroids, in dendritic ulcer will progress to geographic ulcer. It can have its complications. So in active infection, steroids are contraindicated. You give only antiviral ointment. But in contrast, when it is disciform keratitis, I told you disciform keratitis is not active infection. It is immune mediated. So for the treatment, whenever there is immune pathology, you have to give steroids. So you give topical steroids with the antiviral. Okay, so I hope there is no confusion here. When there is active infection, no steroids. When there is disciform keratitis, which is immune mediated, we give topical steroids with antiviral. Okay, friends, right? Then there is a third category actually. There is a third category actually, what we call as metaherpetic keratitis. Now, what is this metaherpetic keratitis? Now, in metaherpetic keratitis, like, what is happening? Again, there is no infection now, but the ulceration does not heal. We call this ulceration as neurotrophic ulceration. Now, let me tell you what is neurotrophic means. The corneal sensations are reduced. Now, because of the corneal sensation, the corneal epithelium has its normal integrity. Whenever corneal sensations are reduced, there is always risk of ulceration. And this type of ulceration can occur in the absence of any infection also. That's why it is called neurotrophic. Okay. So I told you in the beginning also, just try to recall that the epithelium is having the barrier function and the cornea is highly sensitive there. So when corneal sensations are decreased, the kind of neurotrophic loss occurs to the corneal epithelium. The corneal epithelium becomes prone to ulceration, and we call it as neurotrophic ulceration. So in a case of herpes infection, the corneal sensations are reduced. So what happens, sometimes the infection is gone, but ulcer is not healing. We call that type of ulcer metaherpetic keratitis. Okay, so in this case, you don't need any antiviral. You will never give steroids. You give treatment to promote healing. You will give lubricant eye drops and you will give bandage contact lens. You will try to promote the healing. That is your metaherpetic keratitis. Okay, so just giving you few minutes to grasp the treatment of herpetic keratitis and what questions can come. Questions can be related to reduced corneal sensations in the viral keratitis. Okay, image of disciform keratitis, I told you. Dendritic first, told you about the dendritic ulcer, geographic ulcer, disciform keratitis, which is immune mediated, the difference of treatment between the epithelial infection and immune mediated, and in the last, metaherpetic keratitis, which is non-healing neurotrophic ulceration, in which you will give supportive treatment to promote the healing. Okay, supportive treatment to promote the healing. Okay, friends, now moving on to the next step here. The second type of the virus which can involve your cornea, as I told you, is herpes zoster. Herpes zoster. So that was all about herpes simplex. Now herpes zoster. Herpes zoster. Now, herpes zoster, we know the virus is more prone to cause infection in elderly people and immunocompromised people. Okay, herpes zoster, as such, the infection occurs in these kind of spectrum. Now, this virus has a tendency to reside in Viserian ganglion of the fifth nerve. And since the fifth nerve is involved with the eye, so involvement of eye is usually seen, and it is known as herpes zoster ophthalmicus. Okay? It is known as herpes zoster ophthalmicus. Now, what's happening over here is this infection starts in the form of skin eruptions, as you can see here. Okay, so patient will have vascular skin eruptions. Patient can have fever, neuralgia, that is the pain, and ocular movement. So there is an important sign by the name of Hutchinson's sign. Hutchinson's sign. Now, what is this Hutchinson's sign? First, you listen and then we can write also for your notes. The Hutchinson signs means See, there is involvement when the vesicles, they involve the tip of the nose. Then the chances of corneal involvement are high. That is called a Hutchinson sign. Okay. That when, now you can write, when tip of nose has vesicular eruptions, that is, this area is involved, the risk or chances of eye involvement are high. When tip of nose has vesicular eruptions or they are seen, the chances of involvement of cornea or eye are high because both they are supplied by nasociliary nerve. So they have the common supply and this virus goes along the nerves. So that is why the chances are high. So this sign is called as Hutchinson sign. So this can be your question. So this is in relation to, we are talking in relation to herpes zoster ophthalmicus. Okay, right? Now, in herpes zoster ophthalmicus, there is another specific feature. So you notice here, again, you see the lesions on the cornea as if they are forming the dendrites, but they are not truly looking like dendrites. We call this type of presentation as pseudodendrites. Now you don't really have to remember this picture, but remember the word pseudodendrites. So the dendritic lesion which is seen in herpes zoster, they are not the true dendrites, they are pseudodendrites. So this can be your question. Okay, that pseudodendrites are seen in herpes zoster ophthalmicus. So you will notice the Hutchinson sign in herpes zoster ophthalmicus. You will notice the pseudodendrites in herpes zoster ophthalmicus. Okay. Now the rest of the things are nearly the same. So I have already told you about pseudodendrites. In stroma, it can cause the nummular lesions. It can also cause disciform keratitis. It can cause keratouveitis. So this is a little bit different involvement than the herpes simplex. Okay, it can cause the subepithelial nummular lesions. We have discussed nummular lesions in the adenoviral conjunctivitis also. It can cause disciform keratitis and it can also cause keratouveitis. The difference in the treatment of herpes zoster is that we give systemic acyclovir also. Okay, so this is the difference. There we were giving only topical acyclovir. Here we will give systemic acyclovir also. Okay, so if I tell you 3 things to remember about herpes zoster ophthalmicus, remember about Hutchinson sign, remember about pseudodendrite, and remember about that you will give systemic acyclovir tablets. Okay, not only the ointment, the tablets are also given. Okay, right? Okay, so we are now done with bacterial keratitis, fungal keratitis, viral keratitis, some miscellaneous type of keratitis which are important from exam point of view. Let's go ahead and do these also. So in miscellaneous keratitis, the most commonly asked is your acanthamoeba keratitis. Again, a high yield topic for the exam. The keratitis caused by acanthamoeba. Now, what is acanthamoeba? Acanthamoeba is a protozoan. Okay. The acanthamoeba infection is more common in people which are contact lens user. Just like fungus, if it is trauma with the vegetative matter, they can also have acanthamoeba. use of muddy water to clean face. So, contact lens with poor hygiene, trauma, use of muddy water, all these, they can be there in the history. Now, the difference from the other type of the ulcer and acanthamoeba ulcer is, it is severely painful ulcer. Okay, very, very painful ulcer. Why? Because it involves the corneal nerves also. It involves the corneal nerves also. It causes keratoneuritis. So the ulcer is extremely painful. So that is one specific feature of acanthamoeba. Okay. Now then, in the signs, this typically produces, as you see the lesion here, this typically produces what is called ring ulcer. Ring ulcer. Okay, right? Ring ulcer. So, keratoneuritis, which leads to severe pain, ring ulcer, these are two specific features of acanthamoeba to identify acanthamoeba. Okay, so these can be the important question points also. Okay, so let me just go back here. So how the question can come? So there can be a clinical case scenario. So you can mark it as that it can come as a clinical case scenario. How? They will say that a 26-year-old girl, which was a contact lens user, and she used to use the regular saline water for cleaning the contact lenses, not the proper solution, now comes to the eye OPD with severe pain in the eyes. Okay. On examination, a ring ulcer is seen. So these key points, okay. So whenever there is a case scenario, you have to extract the key points and then relate what you learned in the theory to find out the diagnosis. So contact lens user, poor hygiene, very painful ulcer, ring ulcer, they are the things which will tell me that they are talking about acanthamoeba ulcer. Okay, right? So this is how I will be able to attempt this kind of question. And then acanthamoeba is a protozoa. So the treatment of the acanthamoeba ulcer, the drug of the choice is polyhexamethylene biguanide and propamidine. So this can also be asked, the drug of choice for acanthamoeba. The drug of choice for acanthamoeba is polyhexamethylene biguanide, PHMB, and propamidine. Okay, so 4-5 points about acanthamoeba keratitis. You learn it and you should be able to attempt every question related to acanthamoeba. Right? Okay. Okay, friends, moving ahead. So far we discussed the infective keratitis, bacterial, fungal, viral, protozoal. Now, few type of keratitis in which there is immune mediation, no infection, immune mediated. Okay. In first type, I'm going to tell you about interstitial keratitis. Interstitial keratitis. The point which you need to know about interstitial keratitis is, interstitial means the stroma is involved without the epithelium involvement. Okay, so there is no ulcer. There is no ulcer because epithelium is not involved. Stroma is involved. The mechanism is immune mediated, not active infection. And this immune mediation can be to herpes, just like disciform keratitis, It can occur due to syphilis and many other. So these are just the examples. So it is immune mediated keratitis. So when I told you, when it is immune mediated, the treatment is in the form of topical steroids. So please remember, interstitial keratitis is immune mediated keratitis, and you can give topical steroid for its treatment. Okay, so that is the point to be remembered, right? Then there is a condition known as Cogan syndrome. So this can be asked as a question. What is Cogan syndrome? Cogan syndrome is a condition in which there is bilateral interstitial keratitis, that both eyes are having interstitial keratitis, and there are vestibulo-auditory ENT symptoms, vestibulo-auditory symptoms also. So that condition is known as Cogan syndrome. So here the treatment of Cogan syndrome is you give systemic as well as topical steroid. So they can ask you, like, Cogan syndrome is bilateral interstitial keratitis having vestibulo-auditory symptom. Okay. Then another ulcer which we should know, which is important for the exam, is your Murren's ulcer. Murren's or rodent ulcer. Murren's, or which is also known as rodent ulcer. Okay, so what is here? So first of all, let's have a look at the figure, and then I tell you. This can come as an image-based question. So please mark it as, it can come as an image-based question. They can show you this picture. So what do you see here? You see here the cornea, the central cornea is okay. It is the peripheral cornea which is showing the ulcer. Okay, so number one, how will you identify Murren ulcer? It is the peripheral cornea which will be involved. And you see the thinning of the cornea. That is why the rodent, like a rodent makes a burrow. The rodents, they make burrow. So similarly here, the ulcer is causing thinning of the cornea, progressive thinning of the cornea. And it gradually tends to involve, like, circumferentially, like all over. So this is the feature of Murren ulcer or rodent ulcer. The ulcer, the features are, number one, what is the reason? We do not know the reason. It is idiopathic, immune mediated. It can involve both the elderly as well as the young patients. The young patients, they have aggressive disease. And please write it down here. It involves peripheral cornea with progressive thinning. Okay, so like a rodent, involves peripheral cornea with progressive thinning, right? So you identify the image from the peripheral ulcer, from the thinning, you know what it is immune mediated. Then if anything is immune mediated, the treatment has to be steroids. Okay, if anything it is immune mediated, the treatment has to be steroid. But since it can be aggressive, so you can give steroids. You might need to do immunosuppressant drugs also. And if there is perforation, it might need keratoplasty, right? So Murren, please remember, it's a type of peripheral ulcer with thinning, immune mediated. The treatment, steroids, you might need immunosuppressants, you might need keratoplasty. These are the points to be remembered about Murren's ulcer. Okay, right? So The ulcers, they continue. Few more things about the ulcer. The next type which we are going to discuss is your neuroparalytic ulcer. Neuroparalytic ulcer. Now, I always tell the class that, like, try to remember the features from the name of the condition. Try to remember the features from the name of the condition. Now, neuroparalytic ulcer means that there is paralysis of some nerve, which is now causing this ulcer. Okay, so here, which nerve is paralyzed? The seventh nerve. What is the seventh nerve, students? Friends? Facial nerve. Now you will ask me, what is the facial nerve doing for the eye? So please write it down. The facial nerve supplies orbicularis oculi muscle. In the eye, the relation of the facial nerve is that the facial nerve or the seventh nerve supplies orbicularis oculi muscle. What is the function of orbicularis oculi muscle? It causes the eyelid closure. We'll be reading about it in the chapter of eyelids also. So you know your eyelids, you are able to close your eyelids. You squeeze tight your eyelids. You blink. All these actions, they are due to orbicularis oculi muscle. And this muscle is supplied by the facial nerve. Now, when the facial nerve gets palsied, I hope everyone has written, the supplies orbicularis oculi muscle, which causes the eyelid closure. So obviously, when the facial nerve is paralyzed, you will have lag of thalamus. Lag of thalamus means, please write down here, inability to close lids completely. Inability to close the lids completely. So what happens? A part of cornea remains exposed. Right? So you are supposed to close your lids, but your lids, they do not close completely. The lower part of the cornea is exposed. So see here, now you see the figure, please. Okay. Now this patient, even during sleep, the lower part of the cornea remains exposed. So you will find the ulcer in the lower part of cornea. Okay. So when eye is exposed, cornea is exposed, it becomes dry. There is formation of ulcer. This ulcer is known as neuroparalytic ulcer because it has occurred due to the facial nerve palsy. And it is a very painful ulcer because there is no problem with the corneal sensations. The corneal sensations are intact. So it is a painful ulcer. Okay. Besides the seventh nerve palsy, there can be some other causes of exposure of cornea. So exposure of cornea is also known as exposure keratitis. So besides, so one I've already told you, one causes seventh nerve palsy. The other cause is proptosis. What is proptosis? When the eyeball is bulging forward. The protrusion of the eyeball. Protrusion of eyeball, or when the whole eyeball is bulging forward, that is called proptosis. For example, it occurs in thyroid eye disease. So that is one reason for exposure keratitis. If a patient is in coma, You have to tape the eye of the patients, because otherwise the eye will remain exposed. So these are the common causes of exposure keratitis: seventh nerve palsy, proptosis, coma. So for these conditions, how will you treat the patient? The treatment is in the form of lubricants. You patch the eye, okay, keep the cornea covered, or you do what is known as tarsorrhaphy. What the tarsorrhaphy means? You cause adhesion of two eyelids, okay? So I'm not going to go in the details of the process. You make the two eyelids adherent to each other at one point, not like, completely, otherwise the eye will be not able to open. But you bring about adhesion of two eyelids in certain area, that is known as tarsorrhaphy. Okay. So in neuroparalytic ulcer, from exam point of view, they can ask you the cause of the neuroparalytic ulcer. That will be facial nerve palsy. You can remember the facial nerve supplies the orbicularis oculi muscle. You can remember that the lag of thalamus is caused due to, that can be a question, lag of thalamus is caused due to facial nerve palsy. Okay. And the other causes of exposure keratitis, that is seventh nerve palsy, proptosis, and a comatose patient can have neuroparalytic ulcer. Okay, right? Now, a similar sounding, but very different type of the ulcer is neurotrophic. Neurotrophic. So please come here, neurotrophic. So I told you one type of neurotrophic ulcer just few hours back. Anybody remembering at the moment? Friends, one type of the neurotrophic ulcer we discussed? Metaherpetic. Yeah, metaherpetic. So neurotrophic ulcer is the ulcer I told you which is caused due to reduced corneal sensations. So whenever there is reduced corneal sensation, there is a tendency for development of an ulcer which is painless because there are no corneal sensations. So what can be the causes of neurotrophic ulcers? So they are actually the causes of reduced corneal sensation. So first of all, fifth nerve, the trigeminal nerve palsy. Diabetics, they can have reduced corneal sensations. Patient of leprosy. Herpes viral, we already discussed. Patients which have suffered cardiovascular accident, cerebrovascular, is not cardio, sorry, cerebrovascular accidents, because that leads to the fifth nerve involvement, and the brain tumors leading to the fifth nerve involvement. So all these, they can be causes of neurotrophic ulcer. Okay. So difference here is that here the ulcer is in the center. You see, the ulcer is in the center. Neuroparalytic in the lower part of the cornea. Here the ulcer is in the center. There it was very painful ulcer. Here the patient may not even know that he is having an ulcer because it is painless. Okay? The treatment remains the same, that you have to promote the healing. You have to promote the healing. Okay. And how do we promote the healing? Just like the last time I told you, you give lubricant, you patch the eye, you do the tarsorrhaphy. So the treatment of neuroparalytic and neurotrophic remains the same, though they are different type of ulcers and the etiology is absolutely different. Okay, so the question can come based upon the causes of what is the cause of neurotrophic ulcer, what is the cause of neuroparalytic ulcer. So please do not confuse that. Neuroparalytic, seventh nerve palsy, trophic, reduced corneal sensations. Okay, right? Okay, so give yourself a pause because we are going to start an important topic again, hygiene topic, in which the questions they have been coming repeatedly. Okay. So the last topic of today, and give yourself a few deep breaths there so that we can start with the next topic here. Yeah, ready guys? Okay, so now leaving the ulcers and the keratitis behind, take a deep breath. We are moving on to the next category of the diseases, which is your ectatic corneal diseases. Ectatic corneal diseases. So what do you mean by ectasia? Ectasia word I already used. Ectasia means when there is like, bulging. Ectasia as such means bulging. So bulging means when the cornea is bulging means the curvature of the cornea is changed. The normal cornea has its curvature, but when the curvature of the cornea is changed, it is bulging or protruding out. So there are certain conditions in which there occurs corneal ectasia. Okay. So in the category of corneal ectasia, the three diseases they are considered. Most importantly, keratoconus. Then there is another condition by name of keratoglobus. And the third type is called pellucid marginal degeneration. Okay. So here you have to understand, now we are discussing the infection keratitis is over. We are discussing ectatic corneal diseases. Ectatic means the cornea is protruding. When cornea is protruding, it means there is change in the corneal curvature, right? The three diseases come in this category: keratoconus, keratoglobus, and pellucid marginal degeneration. Okay? So I want you to first focus on keratoconus. Keratoconus. Now this is an important topic. Please pay your full attention here. Keratoconus, so first of all, it is a non-inflammatory disease. Okay, there is no inflammation involved. Why this is happening, we do not know. It is a non-inflammatory disease. It is bilateral. Okay, both eyes are involved, though it can be asymmetrical. Asymmetrical means that one eye may be involved more severely than the other eye, or the presentation may not be simultaneous. That one eye is involved after a few years, the other eye is involved. Okay, but it is always bilateral. More common in males. The disease starts at puberty. And what is actually happening is there is progressive thinning of the stroma. So we discussed in the anatomy of the cornea that stroma forms the 90% of the thickness of the cornea. Now what is happening in keratoconus? The stroma is becoming thinned out. So when stroma will become thin out, that particular area of the cornea becomes protruded. Okay. So actually, if you see the word keratoconus, kerato means cornea, conus means cone-like. So you can remember it by, conical cornea. In simple words, if I have to remember that what is happening in keratoconus, it is conical cornea. Okay. Why the cornea is becoming conical? Because of the thinning of the stroma. Because of the thinning of the stroma. The normal shape of the cornea is like this, the spherical. But in keratoconus, it becomes conical. Right? Why I'm telling you to make a concept? Because that will help you remembering all the clinical signs in keratoconus. The cornea has become conical. So if you have this concept in mind, you can have, it will be very easy to remember all the signs, symptoms in the keratoconus. Okay. So you now remember the features. The cornea is becoming conical due to stromal thinning. This is more common in males. It is bilateral, though it can be asymmetrical. The disease does not start at the birth. It starts at puberty. But why it is happening, actually, we do not know. It is a non-inflammatory disease. There have been certain associations of keratoconus. In eye, the patients of retinitis pigmentosa, which is a disease of retina, they also have keratoconus. Okay. There are certain systemic associations. The patients of Marfan syndrome, Down syndrome, Ehlers-Danlos syndrome, they can have keratoconus. Okay. So these are the ocular and systemic manifestations. Now, what are the different signs which you see? And these signs are very important, very high yield, because they can be asked as the question, the theory as well as image-based question. So I'm going to make, first of all, read these, then we will understand what are these signs so that it helps us in retaining them. Okay. So first of all, you have to understand, as I'm telling you, that the corneal curvature, when cornea becomes conical, the corneal curvature changes. When corneal curvature changes, the person will have irregular astigmatism. Astigmatism is a type of refractive error. So here the patient is going to have irregular astigmatism. So this gives a specific sign which is known as Rizzuti sign. What is Rizzuti sign? There is scissoring reflex on retinoscopy. So retinoscopy is measurement of refractive error. You can write here. We'll be discussing it in the later chapters also. So it is a method to measure refractive error, retinoscopy. So in a patient, when they do retinoscopy, there is seen scissoring reflex. And this sign is known as Rizzuti sign. Okay. Then the second sign which we see is called oil droplet reflex. So this is seen when we do a procedure called distant direct ophthalmoscopy. So these terms may be like, at the moment you might not be knowing these. This is another type of examination method, distant direct ophthalmoscopy. If you want to write it here, you can write also. DDO means distant direct ophthalmoscopy. Okay, so because of the conical cornea, we see an oil droplet reflex. Please remember that. Okay. Then I told you about placido disc, those rings like. So when the cornea becomes irregular, you can diagnose that on the placido disc examination. So all these signs are happening, as I told you, because corneal curvature has become irregular. It has become conical, right? Then there is another sign which is called Munson sign. I will just show you what is Munson sign. So please have a look here. Now both these images, they can come as image-based question. Image question, image question. Please write it down. They can come as image question. Right? See, this is the site when you are looking at the patient. The shape of the cornea has become conical. Right? Now, because of this, when the patient looks down, the eyelid also show this V-shaped sign, because the conical cornea is making the eyelid bulge also. You got that? The cornea is conical. When the patient looks down, the eyelid also becomes like V-shaped or conical. This sign is known as Munson sign. So they can show you the image and ask you to identify the sign or identify the disease. So we can do this because we can see here, this is the image of keratoconus, conical cornea. It is making the eyelid also conical, appearing V-like. This is the Munson sign. Okay, friends, right? Then if you do the slit lamp examination of these patients, you can notice the stroma thinning, because cornea, you will be able to notice the stromal thinning there. Then you can also notice vogue stria. Because cornea is becoming thin, there are thin folds in the cornea. The vertical folds seen in the descemet membrane layer. They are known as vogue stria. Okay. And lastly, the sign of Fleischer ring. Fleischer ring. Now, Fleischer ring is an iron ring in the epithelium. Iron ring in the epithelium, iron deposition in the epithelium. Okay. So I'm going to revise with you, because each of this can be asked in the exam as a question, and the image of Munson sign or the keratoconus can be given as an image-based question. Okay, so please do not forget that. So what are the signs? Let's revise. Because of the irregular astigmatism, you will see a scissoring reflex on the procedure of retinoscopy. This sign is called rhizoutism, right? Then when we do the procedure of distant direct ophthalmoscopy, then because of the conical shape of the cornea, we will notice an oil droplet reflex. Okay. Then again, because of irregular cornea, when we do the placido disc examination, we will see irregular rings there. Okay. Then fourth is Munson sign. Munson sign, when patient looks down, the eyelid also appears V-like because of the conical cornea. Right? Then you will see vogue stria. Vogue stria, they are the folds in the descemet membrane, vertical folds in the descemet membrane. Okay. And then you see Fleischer ring, which is the iron deposition at the base of the cone, iron deposition in cornea. Okay. So here I'm going to make you revise one more iron deposition which we have read today. Stalker line in pterygium. Stalker line in pterygium. And another iron deposition I'm telling you at the moment, Fleischer ring. Fleischer ring, which is the iron ring seen in keratoconus. Iron ring seen in keratoconus. Okay, friends. So these, try to remember all these signs, and I have tried to make you give an idea how to remember all these signs. So please remember, all these signs are because of irregular conical shape of the cornea. And of course, because of the thinning of the stroma, Now, what happens in a patient of keratoconus? Now, when there is irregular astigmatism, the patient will have difficulty in the vision. Okay, so patient will have decreased vision. Now, when the cornea is becoming very thin, so it will be like, it can become so thin that the normal integrity goes away. So we have to support that cornea. The patient will need treatment. And there can also be like, in the disease process, when the cornea has become very thin, the descemet membrane can rupture also. And I told you, descemet membrane, when it ruptures, then there can be chances of the fluid going into the cornea. Okay, so this is what happens as a complication, what is known as corneal hydrops. Sorry. What is known as corneal hydrops. Now, this is just to make you understand this figure. Now, what happens, like, cornea is becoming so thin that there occurs sudden rupture of the descemet membrane. And when there occurs sudden rupture of the descemet membrane, the cornea can become hazy because the fluid enters, hydrops. It becomes hydrated. Once this active procedure kind of is resolved, active sign is resolved, it leads to corneal scarring. It leads to corneal scarring. So this is the progressive damage which is occurring in keratoconus. The cornea is becoming thin. There can be corneal hydrops. There can be corneal scarring. So these patients, they need treatment. You have to treat these patients. And how would you treat these patients? Before treatment, you have to confirm the diagnosis of the keratoconus. So you have certain signs, but you confirm it on the basis of investigation, which will also tell you about the severity of the keratoconus. And what is the investigation of the choice? So please do a correction here. The investigation of the choice is corneal tomography, not topo, tomo. Okay, so everyone, please, the investigation of choice for cornea keratoconus is corneal tomography. Tomography, because as I told you, it will tell me about the anterior corneal curvature also, posterior corneal curvature also. So it is the investigation of choice. Okay, friends. So what we have learned in keratoconus, different signs which are to be remembered. Now, as the keratoconus progresses further, it can cause more vision problem because cornea is becoming thin. The cornea can become scarred. So now I have to think about the treatment. And before management, I will first confirm the diagnosis, which is by the investigation of choice, which is corneal tomography. Now, this is again important point. Okay, right? Now going ahead, in the treatment of the keratoconus depends upon the severity of the disease. Okay, it depends upon the severity of the disease. So what are the different options? Now, in the mild cases when the cornea is not that conical, just some irregular astigmatism is there, I can treat the mild cases by using contact lenses. And the contact lenses which are used here, they are called RGP contact lenses. RGP stands for rigid gas permeable contact lenses. Okay, we'll be discussing in the refraction chapter. Contact lenses can be soft contact lenses. They are not helpful for keratoconus. We have to use rigid gas permeable lenses. Okay, or scleral contact lenses, or a hybrid type. Okay, so these are the special contact lenses. Please remember the name: rigid gas permeable, or scleral, or hybrid type of the contact lenses. The second procedure which is used for the treatment of keratoconus is what is known as collagen cross-linking, also called C3R. Collagen cross-linking, C3R. So what we do here, we put a dye, riboflavin dye, on the cornea, and then we exposed the cornea to ultraviolet rays. Okay, so this is like, just to let you know what is being done here. You put a riboflavin dye on the cornea, and then you expose the cornea to ultraviolet A rays. So what is happening here? Now you can write here, this leads to collagen remodeling. This leads to collagen remodeling, collagen cross-linking procedure, or C3R. Because if the disease is progressive, you want to reduce the progression. So collagen cross-linking can be used to reduce the progression of the keratoconus in suitable cases. Okay, right? Then the third thing which we can use is what is known as intrastromal corneal ring segments. Intrastromal corneal ring segments. They are also known as intacs. Okay, so they are also known as intacs. Now look at this figure. Now this figure had come in the last NEET PG, or I think AIMS exam. Okay, so it is important. It can be repeated in FMG exam also. So we are using these rings. Are you able to see these rings which are there in the cornea? These rings, these semicircular rings, they are placed in the corneal stroma to support the, they give mechanical support to the thin cornea. Okay, so these rings, they are made up of PMMA material. They are made up of PMMA material, the same material which we also use in intraocular lenses. These semicircular rings, they are placed in the stroma and they give mechanical strength to the cornea. Okay, friends, right? So this can be asked again as a question. Now, in the cases in which the scarring has occurred, scarring, okay, so in those cases we have to go for corneal transplant. We have to go for corneal transplant, and we can do the corneal transplant as penetrating keratoplasty, in which whole cornea is replaced, or deep lamellar anterior keratoplasty, because in these cases the corneal endothelium is healthy. So we only replace the epithelium, Bowman membrane, and stroma. Okay, that is partial, it is done. We'll be discussing about keratoplasty also. You will understand it more nicely over there. Okay, so you can use the replace whole of the corneal thickness, or you can leave the normal endothelium descent like that only and just replace the up till the stromal layer. That is deep lamellar anterior keratoplasty. Okay, so I'm revising the treatment of the keratoconus once more, because all these procedures, they can be asked in your exam. So all these procedures, they have been asked and they can be asked in your exam. Okay, so first of all, for mild cases, you will use rigid gas permeable or scleral contact lenses. The question has been asked on the collagen cross linking also. So for the cases which are progressive, we do a procedure called collagen cross linking, or also known as C3R. Okay, to reduce the progression of keratoconus. Fine, friends. In the cases where the cornea has become very thin, for mechanical support, we can do intrastromal corneal ring segments, also known as intacs. So this is again a treatment of keratoconus. And in the cases in which the scarring has occurred, like, when the hydrops occurs, the scarring occurs, then you have to replace the cornea. So you can do penetrating keratoplasty, in which whole of the cornea is replaced, or since endothelium is healthy, you do partial keratoplasty, what we call as deep lamellar anterior keratoplasty. Okay, friends. So all these points about keratoconus, what is keratoconus, different signs of keratoconus, image of keratoconus, Munson sign, treatment of keratoconus, all these are high yield topics which can be asked, which have been asked in the exam. Okay, so please revise the topic of keratoconus nicely there. And just two things before we wrap up the class for today. Another condition I told you, ectatic, was keratoglobus. Now, this is just to differentiate between keratoconus and keratoglobus. Keratoglobus is present since birth. That started at puberty. This is present since birth. Here, there is no conus, no cone-like. The whole of the cornea is bulging, like a globus. So that is why the word globus. So to understand that keratoglobus is another condition in which there is bulging of the cornea, but here no cone-like bulging, the whole of the cornea is bulging. Okay. And then in the pellucid marginal degeneration, the third condition which was there, if I go there, going back to the page, you can come to the page, guys. Page number 61, where this heading was there. So you can mention in the pellucid marginal degeneration, here inferior cornea becomes ectatic. Okay, just for your reference. This is just for your reference. You should know this is another condition in which the cornea is becoming ectatic. In pellucid marginal, that is why the word marginal, the inferior cornea becomes ectatic. Globus, whole of the cornea is bulging forward. And in keratoconus, a cone-shaped bulging is seen. Okay, right? So this was about the different ectatic diseases, right? So I think we have about 10 minutes before the class. So would you mind if I tell you about a very small topic? Okay. Before wrapping up, a very small topic, because that will finish a condition here. Just very, a few typical points are to be remembered about that. Okay, so I think we can do that. Right. So what I'm going to tell you now about is different type of the corneal dystrophies. So we will be doing only the high yield points. No unnecessary, detail of the corneal dystrophy is needed from your exam point of view. Just few important points about the corneal dystrophy which might help in the exam. Okay. Right. So what is corneal dystrophy? Now, dystrophy means that the tissue is not normal. There is some abnormality of the tissue, which is hereditary, which is progressive, that is it increasing over the period of time, bilateral, and non-inflammatory. Okay, so this is for your understanding that which diseases will come under the category of dystrophy. Okay, so dystrophic diseases are hereditary, they are progressive in nature, they involve both the eyes, and they are non-inflammatory. Now, depending upon in cornea, which part of the cornea is having dystrophy, the corneal dystrophy can be anterior dystrophy, then only in anterior dystrophy, the epithelium epithelium and Bowman layer is involved. Okay. So when the disease is affecting only the epithelium and Bowman layer, that type of dystrophy is called anterior dystrophy. When the disease is involving the corneal stroma, then it is called stromal dystrophy. And when the disease is involving the endothelium, then it is called endothelial dystrophy. Right? So in dystrophy, the few high yield points, you must know what is Cogan microcystic dystrophy. It is also known as map dot fingerprint dystrophy. Okay? Because it produces the corneal abrasions like it can be map like, fingerprint like. So these kind of changes, they can be seen in the corneal epithelium. So Cogan microcystic dystrophy is also known as map dot fingerprint dystrophy. It is most common anterior dystrophy. So that is your question. That the most common anterior dystrophy is map dot fingerprint or Cogan microcystic dystrophy. This patient will present in the form of recurrent corneal erosions. Okay, right? Then in stromal dystrophy, three names, remember three names: lattice type of dystrophy, granular, macular. So please remember all these three are stromal dystrophy. And the most common stromal is lattice dystrophy. Okay, most common stromal is lattice dystrophy. And important one is your Fuchs endothelial dystrophy. Fuchs endothelial dystrophy. Now these are typically seen in elderly patient. The patient will suffer from the loss of endothelial cells. And here, what we read earlier will be useful. We know when endothelial cells, they are lost, the cornea can develop corneal decompensation because endothelial pump will be gone. The cornea will become edematous. It will have fluid inside. So what happens in Fuchs endothelial dystrophy? If such patient undergoes cataract surgery, the further loss of endothelial cell can occur, which can lead to corneal decompensation. Corneal decompensation after cataract surgery. Okay, so please remember this point. What I am telling here, because already such patient have less endothelial cell, and cataract surgery can cause more damage to endothelial cells. So these patients can develop corneal decompensation. So in these patients, it is always a good idea to do which investigation which you will do in these patients? Specular microscopy. So we will do specular microscopy because you want to know what is the residual endothelial cells in these patients. Because if the endothelial cells are very less, then you can do combined procedure, keratoplasty with cataract surgery. Because if the cornea becomes hazy, the patient will not be able to see. But if you know beforehand that this patient can have a problem after cataract surgery, which you can diagnose by specular microscopy, then you can manage that patient accordingly. You can do keratoplasty with cataract surgery. Okay, so how the question can come here? The question can be related to Fuchs endothelial dystrophy, that what particular thing you will take care in a patient of Fuchs endothelial dystrophy before cataract surgery. You will always do specular microscopy because you want to know how much are the residual endothelial cells, and then you can manage the patient accordingly. Okay, friends. So this was the point about simple points about the corneal dystrophy, which you should know, which can help in our exam. Right. So here I'm going to wrap up for today. Thank you so much for being so attentive. I hope you got an idea what will be the best way for you to use the workbook. You must have marked the high yield points. Next time when you revise, focus on the high yield points. I have explained you the concept. So to memorize the high yield points, you can use those concepts. You know which question can come as image-based question. You know which question can come as clinical case scenario question. So try to prepare your revision like that. Okay. So thank you so much, friends. Let's meet tomorrow. And tomorrow we will be doing few topics of the cornea which are left. And then we'll be going to the topic of lens, refraction, and maybe if we can start with glaucoma. Okay, right? So see you tomorrow. Thank you so much. I just want to let you know that you can, if you have any query, you can post it to my mail. You can post me on the message on the Telegram, right? You can post on the MIST app there, and I will try to answer your doubts or queries. See you tomorrow for your class. All the best. God bless you. Keep learning, keep revising, be happy, keep healthy. Okay. Thank you so much, friends.